did a really good job holding it, right?
Pretty good.
Do you hear me? Am I good? Am I good? All right. So we're in for the last stretch, the long haul. My hope, who's excited? My hope is that we are able to finish probably a little bit early. We'll have one more break in between. What we're going to be focusing on this half of it is the assessment part as well as treatment, what to actually do. So hopefully that will be helpful to some people. So in terms of assessment, I'm going to go over what my part of the assessment is. Again, I usually am very strict about staying within my scope of practice, but if you are from a different discipline, I still think it'll be very helpful to see some of the different pieces that I go into to consider when you're really trying to get a nice background information on what these children look like based on parents' reports. So the first step that we do, number one, is I always make sure we're doing a phone screen. So before they even come into the clinic or before they come into their office, I always like to make sure that this is worth somebody's time, right? That number one, that they're an appropriate referral. Number two, that I think it's a problem that I can actually address in my clinic. And then I also like to talk to parents about my approach so that if they say, no, thank you, that's not the kind of approach I want with my child, then I haven't wasted their time and I haven't wasted my time. Because again, with a limited amount of time, energy, and resources and money, I want to make sure parents are making the best decision for their child that they feel comfortable with. So I over the phone, it usually takes about 15 minutes, no more than that, try to get a sense, is this a food refusal kind of kid? Is this a food selective kind of kid? What level of support is hypothesized to be needed, right? If it's a tube child, no one should be doing that independently outside of a team, right? So for the food selective kind of kids, sure, if you're an independent clinician, go ahead and do that. But generally with some tube weaning, we're talking about that's more of like a clinic-based or hospital-based type of service to be done. So again, this is a more intense child. Are you able to provide that level of service? Is the presenting problem at a level that you can address? Opportunity to explain your approach to treatment to ensure caregivers agree. So again, I like to make sure that caregivers are very clear about what my approach is, so that they know what they're getting into and they know what they're signing up for when they come in for an evaluation with me. Assessment components, here are all the components that generally are within my, go ahead.
Is that like after you get the referral, then you reach out to them?
Correct. So the way correct. So the way it happens for us is that they'll either call our clinic or send in an email on our website that, you know, how do I schedule an appointment? Well, before you schedule an appointment, let's make sure this is really what you need. There's definitely a lot of times when I've said, you know what, I think this is more of a speech or swallowing concern. Why don't you go there first? And then if that's not a concern, come back to me. Again, because you don't want them to take, at least where we are in our clinic, we have a limited number of slots. So I want to make sure the slots that we're using are the ones that are going to be the most appropriate for us. So in terms of background information, what I look at is what's the presenting problem. Like I said, food refusal versus texture selectivity. How did the child do with introduction of liquids or foods? Get a nice background information of their feeding history. What age did sort of all these problems really begin to occur? What's the child's current diet? So the history, what does it look like now? What do parents do to address feeding concerns? Are they offering food on a regular basis? Have they stopped altogether? I see a lot of parents who at this point just say, no, I don't give them any new foods because I know that there's such problem behavior that there's no point in doing it. It's torture for them. It's torture for us. You know, why do we need that? So no, I don't offer any new foods at this point. And how does the child respond to those attempts or lack thereof? So I gave you a little bit of an example that we'll read through. This is generally what it sounds like. This is the history part of it. So Sarah was brought in for an evaluation. She only eats certain food. As an infant, Sarah was breastfed until 13 months and provided bottles of supplemental formula. It was noted that Sarah experienced reflux with the formula, and she was placed on Nutramigen. So Nutramigen is a pretty elemental formula that that babies get if there's any concern about reflux or those types of things. Again, I didn't put them on that. This is just the report. When transitioning to solids, parents reported Sarah was not interested in solid foods. However, they were able to feed her pureed and higher textured foods. At around the age of 18 months, Sarah began restricting the variety of food she willingly accepted. Mr. and Dr. Gonzalez noted that she does not seem to want to be around food and she does not express hunger. They noted that Sarah used to accept a shake that had milk in it, but began refusing that as well. Caregivers are concerned that Sarah does not receive enough protein in her diet, right? That's the whole background information leading up to where she's going to be today. Currently, right, where is she, what is she doing right now? She severely limits the variety of foods accepted. She refuses all proteins, fruits, and vegetables. She eats a variety of crunchy snack foods like chips, goldfish crackers, Teddy Grahams, and other packaged snacks like Little Bites and fruit snacks. She exclusively drinks water, right? So that's a pretty clear overview of what her diet currently looks like. It's not great, but that's what it looks like. And this is a vignette from one of the clients that we saw in our clinic. So then what happens behaviorally? Mr. and Mrs., I changed her to Mrs. instead of Dr. Gonzalez offers Sarah new foods on a daily basis. This usually occurs during meals when they offer her food from their plate or food that has been prepared for the family. They noted that infrequently, Sarah accepts 1 to 2 small bites of new foods, but after this bite limit, Sarah refuses the target food. When Sarah refuses to eat new foods, caregivers generally remove the feeding demand and do not persist with presenting the food. However, if food does come close to Sarah, she turns her head, pushes away the spoon, and screams. Mr. and Ms. Gonzalez report that to date nothing has been effective in managing problem behaviors during meals, and these problems occur on a daily basis. Right? A pretty good synopsis of what the history was, what she currently eats, and what her diet generally consists of, and then finally, what are parents doing and what do behaviors look like at home based on parent report. Then I like to talk about current feeding practices. What are they currently doing at home? Where does the child sit during the meals, right? Who feeds the child? What does the child have access to during meals? How often is the child fed? How long do meals last? And what does the child drink out of, right? These are going to give some insight. Someone brought up earlier about a spoon. What happens if you could just make a little bit of a change and use a different spoon, or make sure it's not too hot? This is a great time to find out all that information to sort of get a sense of what's going on at home. Well, he doesn't really sit down at the table for meals. He walks around the house. He comes to the table. He takes a bite of food, and then he continues walking. He goes watch TV. He comes back to the table, takes a bite. That's a pretty typical pattern that I hear a lot of in our clinic with regards to children with autism. So here's Sarah. When Sarah is fed at home, she's usually fed while seated at the table in a chair. During meals, she eats with the family. Sarah typically self-feeds using her fingers and utensils, and meals last 20 to 30 minutes on average. Meals or feeding sessions are held 3 times per day with 1 snack. Mr. and Ms. Gonzalez reported that Sarah can drink from all types of cups, including a straw cup and an open cup. Mr. and Ms. Gonzalez believe that the reason why Sarah has problems with feeding situations is related to anxiety with regards to new foods. Now, this is a great place where we find out a lot of information, again, of feeding practices of the family, right? So when parents say, she always has access to the TV, right? She always has access to an iPad. She always has access to my phone. One of the questions that I'll ask on a regular basis is, do you want your family eating in front of the TV? Without any judgment. Sometimes the parents will say, yeah, that's where we all eat. Okay, right? That's not my place to say, well, you guys should be having family dinner. And that's up to the parent as to sort of the environment where they choose to eat and have their meals. So this is a great place for me to get a sense of what do the parents sort of envision their meal times looking like for the family. Also, this is a great time to find out who is feeding the child. There are so many kids that we see where parents or grandparents are still feeding 5-year-olds or 6-year-olds or 7-year-olds or 8-year-olds, right? There is a little bit of a cultural difference in terms of there's a lot of, for some reason I've seen an influx in my clinic the last few months where there's a lot of Latin families, South American families, where grandmother is the primary caregiver, and the grandmothers for these past few families are all feeding their child, even feeding their grandchild, right? Even though they're like 5, 6, 7, 8, right? And I'm working on one of these families to have the child self-feed, right? Again, the child, this is an example, is this an OT issue or is it a behavior issue? Can the child self-feed? Yeah. The kid has dexterity to be able to do all those things. The child is choosing not to self-feed, or the grandmother is choosing not to allow the child to self-feed because for whatever reason he's preferring that, or grandma's preferring that. I also just saw a child where the child wants to self-feed and grandma won't let him. Grandma wants to feed him. And the boy said, I want to feed myself, but she just won't let me. And she says, well, it's very messy when you feed. I know, feeding is like a very messy endeavor, and it's very hard for parents and caregivers to be okay with that mess, but this is a great time during this section to really get a sense of what are the feeding practices at home, what are some of the cultural potentially influencing factors that are setting up that meal piece, right? This is the social aspect of what does a meal look like in your home setting. Also, it's important to get a sense of what general functioning at home is looking like. So even though this is a feeding evaluation, some of those other pieces are really important to get a sense of what does the functioning of a child look like. Overall cognitive functioning, sleep habits or concerns, bowel habits or concerns, to get a sense of what that looks like. Again, as someone who's a psychologist and a behavior analyst, if there's sleep concerns, I can also work with them on that. If there's toileting concerns, I can also work with them on that. As you know, so that's where I get some information on that. And again, this is all parent report. Also, in terms of the bowel habits and concerns, that can give you some insight as to whether or not they need to follow up with some sort of medical provider, right? If there's a lot of diarrhea going on or a lot of constipation, I want that checked out before I work with the child for feeding. Because again, if they're experiencing some sort of pain in relation to feeding, I don't want to start any treatment because I want to make sure that that has gotten taken care of. So those bowel questions are really important to get a sense of what's going on. Are they taking medication for their bowel movements? Are they regular? Are their bowels soft? Are they hard? Those are all really important things, especially if a child potentially is impacted, right, and has been constipated for a long time. It's not going to be comfortable to eat large amounts of food. So again, getting rid of addressing any medical concerns that may arise. What prior feeding interventions has the child had? Right? Have they gone to someone else in the community to address these concerns? If so, how long have they seen that provider? What has that provider recommended? And has that intervention been helpful? Right? Again, that's when I'll say to parents, is it working? Yes. Do you like your provider? Yes. Then you should stay with them. Right? If it's not working, we can talk about what hasn't worked, but then you can also get a sense of what kinds of interventions have already been tried and what haven't been helpful. There we go. Dates, frequency, discipline, interventions, and outcomes. Medical history. I like to know, were there any complications with birth or pregnancy? Are there any food allergies in the family or in the child? Right? Sometimes parents just assume that everyone knows their child has a peanut allergy, but it's really good to know specifically. Other foods that the family may restrict. Like I said, if the family chooses to be vegetarian or a family chooses to restrict some level of food, it's important information to find out. History of medical concerns, current medical concerns, including if ASD is a diagnosis, any surgeries, other physicians involved with the child, right? If the child does have a GI doctor, it's important for you to know who that GI doctor is and potentially even get a release of information so you can speak with that doctor. Same thing for the pediatrician. Current medications, is the child taking anything? This is super important to know. Sometimes kids will be diagnosed a appetite stimulant if there's a volume concern. So being aware of what kind of medications the child is taking. There we go. Supplements, and for what purpose, right? I see a lot of kids taking a lot of very interesting supplements. It's important to know what they're taking before you start working with them. What their family history is, right? Who's living at home, who's taking care of the child, what does that look like? Educational history, where is the child going to school, what grade are they in, what level of support? Is the school targeting feeding? There's definitely a lot of schools where some of the services they might get in school are also addressing feeding if feeding is on their IEP. Not many children have feeding on their IEP, but it could be, or any of the providers or the therapists in the school may still choose to address that in some level. And then we do a meal observation. So this is an important aspect. So what we'll do is we have the luxury of having a one-way mirror, but we don't always do it with a one-way mirror if we don't have that room, where we'll take a look and just tell the parents, similar to what we talked about in those FAU articles previously, feed your child. We want to see what it looks like. Go ahead and feed them some preferred foods. I want to see what it looks like when he's eating well, right? Is the child chewing well? Is the child happy? What does it look like? Do they have an iPad with them? All those different aspects of feeding under the best conditions. I tell parents to feed their child according to what they would naturally do at home. And then we'll do an observation of non-preferred foods. So then 5 minutes of, all right, what does it look like when you really try to get your child to eat those other types of foods? What level of problem behavior is there? What level of crying is there? What level of acceptance is there? And then finally, if appropriate, I may do a feeding probe to see if the child's going to act any different with me than they would with the parents. Now, during this observation, I'm taking data, and we'll talk about data collection in a second, on very specific target behaviors. Is the child accepting the food? Once the child accepts the foods, are they spitting out the food? Are they engaging in problem behavior? Are they crying? I also take data on parent behaviors. How many times does the parent prompt the child to eat? In a 5-minute observation, I just did one on Thursday, where there was over 40 times the parent said, take your bite, come on, take your bite, let's go, eat this one, eat that one, right? That's a really annoying meal, right? For everybody involved. It's a really annoying meal for the child who's just being, pecked at the whole time. Take your bite, come on. I mean, 40 times in 5 minutes, that's 8 prompts a minute. That's more than one every 10 seconds. No one wants to eat under those conditions, right? And it's also stressful for the parents who's continually just nagging and just so stressed and concerned and worried about their child that you can really get a sense of what does a meal look like at home? If this is what it looks like, I understand why everyone is just stressed out, or I understand why the parent's not even trying this anymore, because this is not fun. So we take data on all those types of behaviors. Is the child feeding himself? Is the parent presenting food to the child? So we can get a sense of what that looks like. Now, for all you BCBA people out there and behavioral people out there, what did I not do? What's not on my list? I don't do a functional analysis. I don't do an FA during a feeding evaluation. So a lot of people would say, why? That's sort of the gold standard of behavior. And what I say is a few reasons. Number one is, I just showed you all the literature. And all the literature tells you that it's mostly escape and it's a little bit attention. That's what the literature says. That also sort of cognitively makes sense, that it would be escape and a little bit attention. So do I need to go through an entire FA with a child to spend all that time, to spend the child's time, to spend the parent's time, to do an FA when the research has shown me a lot of information that it's escape and attention, and that it makes sense that it would be escape and attention? So that's why I don't do it. But I do a meal observation and take data on that. Okay, so I think that's an important thing that there's a few clinics. If you go to Dr. Piazza's clinic in Nebraska, they do a functional analysis on every single kid that walks through that door. Every single time there's an FA done. And guess what she finds the function of the behavior is? Escape and attention. Okay, so I sort of skipped some of those steps just for ease and sort of for clinical application. That I think there's been enough research and support out there and enough of my clinical experience out there to feel very confident that it's not a tangible function or a automatic function. So there you go. There's my non-FA piece. So what this looks like, a 10-minute, I think I talked about this a little bit. A 10-minute meal observation was conducted during which Mr. Holmes, we have a new child, offered preferred foods for 5 minutes and non-preferred foods for another 5 minutes using the same methods that he usually presents food in the home setting. Preferred foods included sun chips and fruit gummies. Non-preferred foods included pancakes, which I'm always like, really, you don't eat pancakes? Okay. So I take data on how many bites were accepted. We have 37 preferred bites accepted. All were self-fed. Nothing was spit out. There was no crying, no disruptions, no gags or coughs. And then how many bites of non-preferred? 1. They self-fed, and still no problem behavior, but mostly because there was no acceptance, right? And parents didn't really persist, and we'll talk about that. So this is what my meal observation write-up looks like. During the meal, Alice was seated at the table in a chair, and Mr. Holmes was seated across from her. During the presentation of preferred food, Mr. Holmes placed the food in front of Alice. She responded by independently taking 37 bites, although swallowing was not directly assessed, right? I can't say she swallowed all those bites because I wasn't looking inside her mouth, so this is where it gets a little bit technically behavioral. She didn't spit out any of the foods, and there was no food left in her mouth at the end of the observation. A total of 25 grams were consumed. We weighed the food prior, and we weighed the food post, so I can get a sense of what kind of volume are we talking about. No crying, disruptions, gagging, or coughing were observed. Mr. Holmes issued 2 verbal prompts to eat, and no other feeding demands, and no statements of praise for eating. We also take data on praise. How often did the parents say, great job taking that bite, right? Not very often, but he also didn't have to tell her to eat, right? She took 37 bites sort of by herself because it's a preferred food, no problem. During the presentation of non-preferred foods, Mr. Holmes placed again the food in front of Alice. A total of 1 bite was accepted, An additional 2 prompts to eat were issued by the caregiver and were consumed during the observation. No expels, gags, crying, disruptions, or coughs were observed. No feeding demands or statements of praise were issued by Mr. Holmes during the observation. It's a pretty boring observation. He just sort of sat there and waited for her to take the bite. He told her twice. She didn't do anything, so he said, okay, we're done. All right, that's what you do at home? Great, then that's what you do. You can get a sense of what it looks like. Then I went in to do a probe. I wanted to see, was she going to take any food from me? So next, the licensed psychologist conducted a probe session with a non-preferred food, which was a banana, presenting that food at a rice-sized bolus, right? Super small. Just a piece of rice. It's really easy and really small. During all bites, the licensed psychologist engaged in high-quality attention after Alice accepted the bite. So I had a DRA in place for acceptance. I engaged with her really nicely during that time. For the first 5 bites, if Alice engaged in any refusal behaviors, the bite was removed for 30 seconds. So if she engaged in problem behaviors for those first 5 bites, I said, okay, you don't have to, right? I didn't persist because we're getting to know each other, right? I'm giving her food she doesn't want. Okay, you don't have to. And Alice engaged in refusal behaviors for all 5 bites, escaping all those bites. Shocker, right? If I let her get out of it, she chose to get out of it. So next, I gave her 3 bites. So that the spoon remained at her lips until she took the bite. She rapidly accepted the first bite without problem behavior, and she accepted the next 2 bites after 5 seconds and engaged in refusal behaviors. However, no other problem behavior was there. She didn't spit it out, she didn't cry, she didn't do any of those things. So after 2 bites of her, refusing, that was enough for me to see. I couldn't, there's some kids who will eat beautifully for the therapist in an observation, right? It looks horrible with the parents. I walk in, and it looks fantastic. Kid is eating everything under the sun. That's when, right, all of the students behind the glass mirror go, oh my gosh, you're so good. This is great. This is going to be so easy. And I look at them and say, this is going to be a lot harder because this isn't a feeding problem. This is a parenting problem, right? If they are going to eat for you and they are not going to eat for their parents, that's not a feeding problem, right? They're in the wrong clinic. They need some parenting. I still will help those children, but it's really important to identify what kind of problem are you dealing with here, right? And there are a lot of kids that I see where they will eat great for me out of the gate. And the second that parent steps in the room, it's back to baseline. And it looked just like it did when their parents were in there, right? It's a much different problem to have to address. And it's different interventions to use. So that's usually out of the scope of this talk. But it's important to recognize that that may absolutely happen, that you have a parenting concern and not a feeding concern on your hands. So then there's some diagnoses if you are so able to give a diagnosis under your jurisdiction of your licensure. Generally, I give a diagnosis of F50.8, which is avoidant restrictive food, food intake disorder, and 84.0, which is autism spectrum disorder, and I put by history or report. I did not diagnose them with autism, so I don't put that diagnosis as something that I gave. And then recommendations. Generally, I give very vague and broad recommendations, because I don't expect to be able to give any parents real recommendations at that moment that are going to make a real difference in their home at that time. That's just the truth. Generally, I believe that they need to come in for services in order to be able to get some support. If there is a parent that I think that I can sort of train them in just some solid, good recommendations that they could implement at home, there have been a very few amount of times where I felt that that was appropriate, and I've done that. But for the most part, if they're really having such significant problem behaviors and concerns, there's not much that I can tell parent in sort of like a 20-minute feedback that's going to make a real difference for them at home. So mine are pretty, like I said, pretty general. Continue to present non-preferred food without the expectation of consumption, right? That is, offer new foods as you do now, but don't expect your child to eat it or interact with it. All right, you can still continue to put it on their plate, ask them if they want it, but don't expect them to eat it if they haven't eaten it for the past 5 years. Nothing's going to change, right? Don't tell your child to eat the food or interact it with anyway. If they want it, great. If they don't, okay, right? Because what they're doing at home at this point isn't really making a difference. It's not moving the needle. So why tell them to persist with something or do something when it has what they have in their current repertoire hasn't worked? If your child does interact with the food, right, they smell it, they touch it, they lick it, offer high quality praise. Great job touching that banana. Just give them some nice attention for doing, an appropriate behavior. Restrict all verbal and nonverbal attention for problem behavior. If your child starts to cry or scream in the presence of non-preferred food, don't tell your child to stop crying, just ignore the behavior. All right, this way attention, even negative attention, is not obtained based on mealtime problem behaviors, right? So again, you don't want to have them reinforce problem behavior by giving them attention for that. So I generally, like I said, make very general recommendations. Go ahead and offer if they want it, great. If they don't, okay. What are you going to do about it? Nothing. Come into the clinic and we'll help you. So that's my assessment piece. Questions? Nothing? No one's got anything? It was that thorough of an overview? That's good. All right. Yes.
In that assessment process, based on the severity of the problem behavior, do you kind of give the parents an idea of how much services are needed? Or do you get a grasp of that through the assessment, or you really have to kind of start?
Excellent question. So after an evaluation, I will be able to identify what level of service I think is appropriate for the child. So I didn't really touch on this too much, mostly because I don't think anyone else here works in a multidisciplinary feeding clinic. But generally, if there is a concern, if the child is tube dependent, if the child is mostly formula dependent, and the child does not chew anything, right, not even preferred foods, that's when I will make sure that the SLP on our team is part of that evaluation. Right? Again, if the child is tube dependent, the child is mostly formula dependent, or the child does not chew anything, even preferred foods, I will make sure that the SLP is part of that evaluation. Because it's really important, again, to get that swallow safety down. Are they appropriate to advanced texture? Not my domain. I mean, I can help figure out what the protocol might look like, but I can't assess if that child is ready or appropriate to advanced texture. So in our clinic, we have two levels of services. One is our general outpatient clinic. That's when children will come into the clinic for 45 minutes, once a week. So generally 45 minutes once a week for your typical super picky kid is definitely enough intervention to move them along. Children are generally within the clinic. I would say we see some very meaningful changes in their behavior. When I mean meaningful, I would say that after at least 6 sessions, they are accepting between 2 and 4 new foods at a small bolus, but they're accepting those foods with very limited problem behavior. Within 6 months, I would say children are mostly done with treatment. The children who stay on longer than that, it's because parents change their goals, meaning that parent comes in and says, okay, all I need you to do is if you could just get him to eat 2 proteins, all I need is 2 proteins. I know this kind of parent, because you get him to eat 2 proteins, it's like, okay, well, now, if you can get him to eat 2 more proteins. So, and then all of a sudden it's like, well, can you get him to feed himself? Well, so that's usually part of our whole treatment package, is that not only do children have to be able, I would say, I get in our treatment plan, we get children on board with at least 4 new foods with limited amounts of problem behavior. We say less than 20% of problem behavior within sessions. Children also have to be able to eat it at the appropriate texture for that child. So for children who have oral motor difficulties, that might be pureed food, and that's fine. For children who do have chewing within their repertoire, the goal is to get all that food up to table texture. Children also need to be able to feed themselves those food so that they can have a divided plate and go around their circle and eat all their foods. If we need to get a drink on board, if there's a child who doesn't drink milk and a parent wants that child to drink milk, we'll introduce a drink. We'll also get that child to then self-feed that drink within the meal setting. And then we will train the parent on the final protocol. We will teach the parent how to introduce a new food so that they don't need us anymore to introduce new foods. And then we will ensure that that maintains at home for at least a month before we discharge. Right? So when you're talking about, 6 to 8 months, that's really putting together the whole package of everything, including self-feeding, including parent training, including transitioning it into the home setting, including making sure parents know how to introduce a new food, including making sure that if they don't want an iPad in the meal, we get the iPad out of the meal, right? Sometimes we'll use a preferred item like an iPad in the meal at the beginning to help gain some behavioral momentum and success. But if the parent at the end of the day says, I don't want my child watching the iPad during a meal, then we got to get that iPad out of the meal before we discharge that client. So we will try to our best ability to get out all the treatment components needed to make that meal at home look as natural as possible and based on sort of what the parent's preferred mealtime setting will look like, which again goes back to that social component of feeding and social component of eating, which is an important aspect before discharging a client. That was a long answer. Does that make sense? Go ahead. Go ahead.
Is there also great success of going from the clinic to the natural, the home to the daycare? So for a child that after that is transitioning to daycare, is there a treatment that still works at the daycare?
So, excellent question. Totally excellent question. So my take on meals at school is this. I send my children to school with 3 really awesome lunches. And my kids are good eaters. And I have them choose their food. And they have their preferred foods at school. And I try to make it as easy as possible. And I still get 50% of that food back. Right? And those are my kids who are like optimal eaters. I don't think it's very fair to expect a child with a feeding concern to eat better than my kids at school. So I will generally tell parents that if your child is having a great breakfast with you, your child comes home and has a great dinner with you, send them the easy foods to school, man. Right? Give them the easy stuff at school, because I don't expect a teacher or a sub or a cafeteria monitor to be able to do better than you in sort of like a one-on-one setting. So I'm a little bit of a realist about schools. Now, give your child something that will sustain them and keep them full. So if that's where throughout the day you're fine if throughout the day your child has some Oreos and some Goldfish, send it to school. And you work on the tougher stuff at home, either in the evening or the morning. So that's my school spiel, is that I think school is a really hard time for kids when there's so much going on in an environment where there's a million things happening. And my kids come home and say, well, we didn't even have time to eat today, which I just don't believe that, but fine, right? But that's sort of, school is a really hard place to address it. Now, I do have a few clients right now where they're at school, we're tube weaning them, and they're not eating anything at school. So that's a problem, because they have to have something at school if they're not going to get their tube feed at night. So that's when I'm going into the school and doing a school observation and seeing what I can do to help train the teachers. But that does not happen very often. Oftentimes, it's children who are eating, but the parents but they're not eating their broccoli at school. Well, are they eating their broccoli for you? Yeah, but it's hard. So why would you send it to school? Right? Make it easy. Send them the yogurt and yogurt tube. If you want to do squeezy pouches, send them to school. Fine. But as long as they're having a good meal with the parent, the breakfast and dinner, I'm generally not concerned. Or that's when I'll say, if you really are concerned about that, you should see a nutritionist to see if what your child is getting throughout the day is appropriate given what he's eating at school. But behaviorally, I'm less concerned about it. Does that make sense? You had a question?
Yes, I guess going back to the initial assessment, how much information is it appropriate to share with the parent in that initial, because obviously we don't want to keep things from them or hide things from them, of course. But sometimes I can see it's overwhelming to get all this information. What's so important to address in that first assessment, rather than start giving maybe like advice and suggestions and handouts and all that,
You mean in terms of what I'm telling the parent to do?
Yeah.
So that's why.
Assessment, I'm just wondering if there are certain points that you like to touch that are must.
Yes.
And some that you're like, oh, I'll wait on this.
So that's where it's really important, to know your clientele. Ooh, sorry. To know your clientele. Some parents just want me to keep talking and want more and more and more and more and more information. I can talk, so I will keep talking, right? And I'll talk more and more and more based on what they want. Some parents don't want that, and that's not a good strategy for them, so I won't. Like I said, in addition to these general recommendations, again, I am very clear about my approach. Again, when they sign up for treatment, I want them to know what I am going to do with their child during a session. I think that's only fair for any parent to know what is a treatment session going to look like. So what that usually sounds like is this. Just so you know, I'm a behavioral therapist, I'm a behavioral psychologist. So what that looks like is that your child has learned over time that if they engage in problem behavior, they can get out of a meal. If they cry loud enough, you're not going to make them eat it because they don't like it, right? I launch into my whole thing about food preferences. Why does he like this food and not that food? You saw my whole broccoli slide. You saw my whole banana slide. I talk about that. I talk about the food culture of America, why do kids in America eat mac and cheese as opposed to kids in different countries. I talk about that we can learn to like new flavors, but the way you learn to like new flavors is by trying it again and again and again, and your child's in sort of like this cycle that they don't like it because they don't eat it, so they don't like it, so they don't eat it. They don't like it because they don't eat it. So we have to sort of break that cycle. And I always say that I really believe that your child is really scared of this food, right? It's sort of like if I were to say to you, kids in China eat crickets. Here's a plate of crickets. Here's a whole spoonful of crickets. You would gag and you would also scream and leave the room, just like this child does in response to broccoli, right? So that's an important thing to understand, that if I gave you a certain food, eel, shark fin, some people eat it. I'm not going to eat it. That we would have the same reaction as these children. So the thing is that they just have to have that exposure. So how do I do that? Number one is I'm really fun and I'm really friendly. And everyone who works in my clinic has to be really fun and has to be really friendly, because this is a hard thing. So my job is to find the easiest, the most simple, and the easiest request that I can make of your child with the least amount of problem behavior. I don't come to work every day to make people cry. I actually come home and it's one of those days, if it's been a bad day and kids are crying, especially when, if there's a lot of vomit, it's a bad day. Nobody wants to see a kid vomit. But at the end of the day, we have to come up with something reasonable that your child is going to be able to do. Now, I sort of liken it, right? There's the whole elevator button comparison, right? If you push the elevator button, the elevator comes. You push the elevator button, the elevator comes. If you push the button and the elevator doesn't come, what do? Push the button again, push the button again, push the button again. At some point, you are going to realize that the elevator is broken. Just go use the stairs and you'll get there, right? So our kids, again, we're talking about that mostly escape function. They have learned that over time, if I engage in problem behavior, I get out of it. If I engage in problem behavior, I get out of it. So it's my unfortunate job to not let your child out of it. So am I going to see an increase in problem behavior, just like that elevator button pushing? I am. But we also know that over time, if we're consistent, that behavior should go down. And we'll talk about data collection, but that's why I tell parents, I take copious data. I take data on every single thing your child, every single bite that goes into your child's mouth. Because nobody eats when they're hysterically crying. I don't eat when I'm hysterically crying, maybe depressively crying, eat ice cream. That's different, right? I am not hysterically screaming my head off when I sit down for a meal. So the first thing that is the most important thing for me is that your child is going to be sitting there calmly with me. But I do expect there to be an increase in problem behavior before it goes down, just like what we all do with an elevator or a Coke machine, right? So what I tell parents is, give me 2 sessions. If after 2 sessions your child is still really upset, then I better figure something else out. That's my job and that's my role. If by session 4 your child is still upset for 45 minutes straight, you shouldn't come back. And I feel pretty confident telling parents that. But generally what I will tell you, kids are upset for 10 minutes. And then we're having a great time. And we're watching PJ Masks. And then they're calm. And because I've found the right place to start, and we're going to talk about that in the treatment section, finding the right place to start for each child is super, super important. So that's sort of the spiel that I give. And I feel very confident telling parents, if you are not comfortable with that, don't come here. And that's okay. You have to make the best choice for your child. But again, I will take data on everything, and you can watch most of it. If at any point you are not comfortable with something that I'm doing, let me know. And if your child is still that upset after 2 sessions, I better think of something else quick. And the other thing I say is, like, I always have my mom goggles on. If I'm looking at this session, there are definitely sessions where I'm like, I'm stopping. This does not, if I was the parent, I wouldn't want this to happen, so I stop. Or the parent has said, I don't think the parent has actually ever stopped me. But there's times when I have stopped. There is a time when a parent said, why'd you stop? And I'm like, no, it's not a good thing. Let's try something else, please. So, right, but there's very few, and when I think of all the sessions that I run, there are very few sessions where a child is that upset for an extended amount of time across multiple sessions. Go ahead.
How much of a factor is anxiety, especially with ASD?
That's a great question. Define anxiety.
Irrational fear and being stuck.
Right, sort of like a phobia, right? Definitely you can conceptualize it a few different ways. You could absolutely conceptualize this as food neophobia, right? A fear of new things, the food being a new thing. So if you look back, that's what I say, if you look back at all the research, and if you look back at all the recommendations for treating a specific phobia, fear of heights, fear of dogs, fear of airplanes, what's the intervention strategy? Exposure and response prevention. That's exactly what we're going to be doing. You got to expose, you come up with a hierarchy, right? A hierarchy, you start at the bottom of that hierarchy, but you do have to have low levels of exposure until that child is habituated to that low level of exposure, right? That's where I take data. Then you go to the next level of exposure, make sure that child is habituated to that level of exposure. That's where I take my data. And then same concept, right? So whether it's a behavioral concern, whether it's a phobia. I mean, I've treated a typically developing 16-year-old who had huge food neophobia. And why did he come to me at 16? Because all of a sudden it's impacting his social life. And it's really embarrassing how he eats and what he eats. Everyone's making fun of him. And he's embarrassed to go on dates with girls, right? So that was much more, again, I'm a psychologist, so I have a little bit more, maybe a broader toolbox sometimes. But that was like straight up phobia, exposure, response prevention kind of intervention with him, where we talked about his level of distress, and after each bite, he rated it on a scale of 0 to 5. But same concept of exposure, just sort of how are you doing it and how are you taking your data. Was there a question back? We're gonna get there. We're going to totally get there, right? That would be horrible. I said, all right, great night to meet you all. We're all done now. That wouldn't be fair. All right, so we have a good amount of time to talk about the last section. All right, any other questions before we move on about assessment, concepts, any of that stuff? All right, good. I'm going to open up my next bottle of water, and then we'll move on. Okay, So part 4, at some point we'll go through this. Some point someone will say, can we have a break? Or I'll say, let's take a break. We'll have one more break in this section, and then we'll bring it home. I told you I was going to talk about it a lot and hit this home very clearly at multiple points. You must and should have medical clearance if there's any concern that there's an underlying medical reason that the child does not eat. Everyone got that point, right? Okay, good. If there's one thing I really want you to take home, there could be an appropriate medical reason that this child is not eating. So before you start treatment, you must have some sort of medical clearance or document why there should be no medical clearance, right? My child used to eat all these foods. The doctor said there's no medical reason for it. Okay. Potentially even get a note from that doctor saying, no medical concerns, go full steam ahead. So the first thing we're going to talk about is operational definitions, right? If you are going to be taking data on target behaviors, you need to know what behaviors you are actually taking data on. So when we talk about eating behaviors, here are the steps. What I like to do, what every good behavior analyst likes to do, is to break down the steps of different tasks. So if I were to ask you, what are the steps of eating? What are the things that you need to do to actually eat? These are the broad strokes of it. One is you need to sit calmly at a table or sit calmly somewhere, stand calmly somewhere. Again, I'm not screaming my head off when I am eating food. You need to accept the bite. Open up your mouth, put it in, and accept that bite. You need to be able to do that. Then you need to maintain the bite in your mouth. It needs to stay inside. You then need to chew and process that food to swallow the bites. And finally, you have to maintain that food in your stomach. Okay? If we were to break up the eating components, it would look like that. Now, there are disruptions that we see during meal times for each of these steps of behavior. Instead of sitting calmly at a table, child could be crying or getting up and leaving the table. Instead of accepting the bite, we see children turning their heads, batting their lips, or just closing their lips. Instead of maintaining the bite in their mouth, they're expelling it, they're spitting it out. Instead of chewing and swallowing it, they're packing it, right? They're holding it in their cheeks or holding it on their tongue or holding it somewhere. And instead of maintaining the food in their stomach, they are vomiting. Okay? So these are all really the different, when I'm talking about target behaviors, these are all of my target behaviors. The behaviors that I want to reinforce and the behaviors that I want to punish. Let's say go down. I hate the term punishment. I think Skinner would have changed it too. I hate that term. So operational definitions are really important, right? Why are they important? First of all, they need to be clear. I need to be able to make sure that if we're taking data, that my data are going to look the same as your data. They need to be concise. They need to be very clear for very specific behaviors. They need to be observable, right? I can't take data on the child thinking the food is gross. I have no clue what the child is thinking. And they need to be able to be measurable, right? How often is a behavior occurring? And what rate and what duration? So, just as a brief overview of data collection before we start our data collection, exciting data collection segment of this program, right? There's a few different types of data that you can collect, and you'll decide what's going to be the best type of data collect based on the problems that you're seeing or based on the client. So one is occurrence data, right? Did the behavior occur during the trial? Yes? No. Did the child spit out the bite? Yes or no? Very clear. Yes or no responses here. Versus frequency data. Frequency data is how many times did the behavior occur? How many times did that child spit out the bite? If I put it back in their mouth, how many times did they spit out that bite until they swallowed it? Maybe they spit it out 5 times. Or there's duration data. How long did the behavior occur? This is much more appropriate for something like crying, right? How long was the child crying for? 3 minutes versus 10 minutes? Hopefully not 45 minutes because that's a long session, 45 minutes of crying. So we're going to watch this video, and then we're going to talk about sort of, if you're thinking about, I want you to watch this video through the lens of occurrence data, frequency data, duration data. We could take different types of data for the different behaviors that we see, so we'll discuss that afterwards. Let's try this. Uh-oh. All right, so number one public service announcement. Don't do that to your kid, man. That's horrible. So we're going to take some data. Hold on. So the part that, first of all, these videos are always really good for my presentations. But the parent who's, number one, driving and taking a video of their child, you should at least pulled over if you're going to take a video. Number one, public safety service announcement. Number two, you're egging on problem behavior. That's just so mean. And number three, don't put it on YouTube. Seriously. So, gosh, right? So those are all the things I have to say about this video, but it's really helpful in my presentation that it happened to be on there, okay? So I had no part in putting this on there. So what kind of data can we take? Frequency on? What else can we take frequency on? Kicking, right? How many times did she kick? How many times did she spit? Yeah, parent behavior, right? Oh, gosh, I was debating, do I use this video or not? It makes me feel like a horrible person, but it's a good video for data collection. So what about occurrence? Occurrence would be, did she spit? Yes or no? Did she kick? Yes or no? Did she scream? Yes or no? Did she cry? Yes or no? What about duration? Crying, right? The duration of crying, the duration of unsafe seating behavior in a car. Again, if your child is sitting like that, you should pull over and appropriately buckle them in their car seat. So those are all the examples of the different kinds of behaviors that we can take. And different behaviors will give you different information. Again, she spat. Did anyone count? 8? There you go. She 8 to 9 times, okay? We have some we'll take some interrelated liability later. But she spat between 8 to 9 times. Now, if you're taking occurrence data, if she spat 9 times, did it happen, yes or no? If she spat 1 time, did it happen, yes or no? Yes. But if you have a treatment in place and she spits 9 times and then she spits 1 time, that treatment could be an effective treatment. We see a really nice decrease in problem behavior, but if you're only taking occurrence data, you're going to miss it. Did she spit the first time? Yes. Did she spit the second time? Yes. No behavior change. But if you take frequency data, did she spit the first time 9 times? Second time 1 time? All right, now we have some data that's actually meaningful for us. So the type of data that you choose to take is going to affect how you analyze those data. And if you can get a sense of if you're actually making a difference and impacting the behavior. So data collection is really important, and the first step of that is really identifying what type of behavior you want to take. Does that make sense? Okay. All right, 1P. Why do I have 1P on that board? All the people in my clinic are smiling because a lot of our definitions and the operational definitions that we have are based on the concept of 1 green P. And we'll talk about what that means. So when I talk about 1P, I'm talking about 1P. When I talk about 2 Ps, I'm talking about 2 Ps, okay? And you'll see how that really comes into play with some of our operational definitions. I'm going to be sharing our operational definitions with you. They're super nerdy behavioral. I'm giving you a preview right now, giving you a warning right now, mostly because these have been the operational definitions that have been used in the literature throughout the years. I would not be surprised if these are word for word behavioral operational definitions that were written by Kathleen Piazza at some point when she was up in Atlanta, and those are still the ones that are generally used within the at least the research literature and then within the clinical literature when we're talking about data collection. So that's why they're pretty technical. So 5-second acceptance. First of all, there's a difference between self-feeder and non-self-feeder, and we'll talk about that throughout. We'll talk about sort of what the definitions are, and then going to your point, how do you decide if you're going to use a self-feeder protocol or a non-self-feeder protocol. So 5-second acceptance. You're going to score this, and this is occurrence. Did it happen? Yes or no? Meaning, did the child take that bite within 5 seconds? But what does it mean if a child takes a bite? So let's look at that. When the child opens his or her mouth and the entire bite is deposited within 5 seconds of the initial presentation, right? If they are crying, right? Do you put the bite in? You usually wait until the kid's not actively screaming, then you deposit that bite. Yawning and are talking, but with the exception of gagging, coughing, or retching. Don't put food in a child's mouth if they're gagging or coughing or retching or taking a deep breath in. That's my disclaimer right there, okay? But the star, if anything larger than the size of a pea, remember our pea, our friend the pea? Anything larger than the size of a pea remains on the spoon after the initial deposit. This would not be considered a 5-second acceptance unless you're able to deposit what remains in the 5 seconds criterion. Food residue smaller than the size of a pea left on the spoon does not need to be represented. Meaning, if you put, say, let's talk about applesauce, right? Easy option. You put the spoon in, the child takes most of the food, but there's more than sort of when you think of like 1 green pea left on there of what would be a pureed green pea down. If that's left on, more than that is left on the spoon, 5 seconds passes, not 5-second acceptance. You have to, but if you take the spoon out, there's still some food in there, and then redeposit, and all that happens in 5 seconds, 5-second acceptance. All right, very clear definition of what 5-second acceptance looks like. Now, greater than 5-second acceptance, when the entire bite is deposited in the child's mouth after 5 seconds of the initial presentation. So it looks like this. When you say, take your bite, 1, 2, 3, 4, 5. Does the child take this entire bolus, except for 1 green pea, during that initial 5-second presentation? This is self-feeder acceptance, right? So there's different protocols and different operational definitions for a self-feeder protocol versus a non-self-feeder protocol. So if the child is self-feeding, right? How do we teach self-feeding? Generally, are people familiar with the 3-step, before I go to I, people familiar with the 3-step, help me out somebody, 3-step, 3-term contingency, not 3-term contingency, guided compliance, thank you. Goodness gracious, I've been talking for a long time. 3-step guided compliance, right? What does that generally look like? It generally looks like this. Say I want a child to sit in a chair. I'm going to say something like, sit in your chair. That's my verbal prompt. They don't listen after 5 seconds. I'm going to say, sit in your chair like this. You do it. I'm going to give them a gestural. Let me show you what I'm talking about when I sit in the chair. And if they don't sit in their chair after 5 seconds, then I'm going to help them and guide them to sit in your chair like this. And I'm going to guide them to physically sit in their chair. That is 3-step guided compliance. Well, we sort of have like 4 steps here in feeding because we like to be a little bit different. So the 4th step is an independent take. Because if the food is in front of you, or the food is in front of the child, they have an opportunity to just, take that bite. So we have our independent acceptance, right? This should be scored when the entire bite is independently accepted within 5 seconds of the bite presentation. For example, the child must put the entire spoon in his or her mouth without a prompt and clear the bolus off the spoon with the exception of a size of a pea. All right, so you put a plate in front of a kid with the spoon already filled. Do they take that spoon by themselves and eat it? Yes or no? If they do, independent. If after 5 seconds they don't take that bite, we go into our general 3-step guide to compliance. What do you say? Take your bite. Do they then pick up the spoon and take their bite? Yes, then they accept it after the verbal. If they don't do it after 5 seconds, they have an opportunity for a gestural, right? I have a spoon on my side and I say, take your bite like this. You do it. If they take their bite after that spoon, then it would be counted as a gestural. And if not, then I'm going to physically guide them. Take your bite like this. So we're going to either score an I, a V, a G, or a P. Now, success criteria would be any of the first 3, I, V, or G, as long as they take it without you needing to physically guide them. Now, we'll talk about what happens if they, fight against you. This is just an operational definition of what acceptance looks like. We'll talk about more of like how to implement it in a bit. The next thing is expel, right? So we talked about, our acceptance. Now we're talking about our expel. So score anytime food or drink larger than the size of a pea, which has not yet been swallowed, right? Very clear. You can't have swallowed it and then spit it out because then that's vomiting. But which has already been placed in the mouth, is visible outside the lips at any time during a bite trial. Okay? So this is a great example where initially I take occurrence data on this. Did the child expel, yes or no? But there are times when we may have a new protocol in place that if you spit it out, bud, I'm sorry, you got to take that bite. And we either get a new scoop and put it in, and if they keep spitting it out, we'll take then frequency data. How many times does a child spit out a bite? So that we can say, did expels happen? Yes. In the first session, we had about 20 expels per bite. In the second session, we had 5 expels per bite. That's progress. In the next session, we had 1 expel per bite. Much better, right? So just a simple yes or no would not have been helpful, but being able to take frequency data on how long did it occur is going to be a lot more telling and meaningful type of data to take. Mouth clean. So this is where we're identifying if the child is actually swallowing the food. So what this looks like is that after every bite, we look inside the kid's mouth and we see if they swallowed the food. So we do a mouth clean check, which generally looks like this. So 30 seconds elapses, and I say, show me. This is our 3-step guided compliance. The child either shows me or not. If they don't, then I say, show me like this. And if they don't show me, I have a baby-coated spoon. It's like one of those baby Gerber spoons that's like plastic on the end or rubber on the end and like a metal. And then I'll help them. I'll put the spoon up and wait for them to open so I can check inside their mouth. And I'll say, so show me like this. Show me, and then I'll physically guide them to help open their mouth to decide if they've swallowed the food or not. Right? That's how we assess swallowing. For some kids, I take that out pretty quickly. For some kids, if packing is not an issue and I don't need to do that, I'll take it out pretty quickly. But if there's a child who's having an issue with packing, we'll make sure that we're checking those mouth cleans. So the opposite of a mouth clean is a pack. Score when any food or drink larger than the size of a pea is visible in the child's mouth 30 seconds after the entire bolus was initially deposited. So after you deposit the entire bolus, you check after 30 seconds. Say they have we're at a full spoonful. And, a full spoonful is about 5 peas, if you imagine 5 peas on a spoon. So if they swallow 3 peas and 2 peas are left in there, still counted as a pack, right? They didn't swallow everything except that one green pea. But if there's just some food residue in there that if you were to gather it all up, it's smaller than that pea, then then that is not a pack, and that would be a mouth clean. Crying or negative vocalization. So you're going to score this when the child cries, screams, whines, swears, or makes negative statements, refusal statements regarding the food or bite or drink. The child must be engaging in negative vocalizations for 3 seconds in order to score an occurrence. So if you are taking data by yourself, you can either score the occurrence of crying. Did crying happen, yes or no? You could take the duration of crying, but sometimes that's really hard to do. If you have one person, you need like 2 timers. 1 person, 2 timers who is feeding and also taking data and also pushing timers. You just need a few more arms, and then you should totally be able to do it just fine. But I can't. So usually I just do the occurrence. Now, if I'm really concerned about latency, then I'll bring someone else in to take some time. But generally, if we can just score occurrence over a few sessions, we'll see that crying decreases over time, if there is any crying at all. Also, what we have is 3 consecutive seconds to score crying. And the reason for that is we see a lot of kids who'll be like, is that crying? It's whining. Crying is real crying, or what's the saddest is the silent cry, right? When they're just the tears, it's very sad. Doesn't happen often, and it doesn't happen for very long, but that's always the saddest cry. So that's negative vocalizations. And then CIs. This is a very important data point. This is combined inappropriate behaviors. Head turns. So again, this is very, very specific. Score each time the child turns his or her head and or body 45 degrees past midline. All right? I'm straight this way. I'm 90 degrees this way. About 45 degrees this way. Right? So if I go like this, right? That's about 45 degrees. That's a CI. Right? Now if I just go like this, not 45 degrees. All right? So again, what level of problem behavior are we actually trying to capture? Or greater than 2 inches away or back during the presentation of the bite or drink. So if a child goes like this, right? That's a refusal behavior. They're trying to get away from that spoon. This is only to be scored during the presentation or representation of their drink. Right? So after you deposit the drink, or after you deposit the bite, the child's looking around. That's not a CI because it's not in response to the food. Right? Or if you're doing that mouth clean check, show me like this, and the child's like this, I'm not counting that as a CI because it's not in response to the food. They don't want me to check inside their mouth, but it doesn't have to do with the stimulus of the food that they're actually engaging those behaviors based on. Does that make sense? So also disruptions. Every time the child pushes or touches the spoon or plate or the feeder's arm, right? So instead of turning their head, they could be trying to bat at the spoon and push your hand away. That's a disruption. Again, during the presentation or representation of the bite, if they do that to me after I've already put the spoon down, that doesn't count. Also score whenever the child attempts to block access to her mouth by placing a toy or one or both hands within 2 inches in front of her face, right? One of those, that counts as a disruption. And you can add any operational definitions that you need. So for example, we talked about expel being only a 1p amount or more. Well, what happens if you were like that little girl and we're at a rice-sized bolus and she's spitting it out? Now, it doesn't count as an expel because it doesn't meet our operation definition of expel, but you could put it an operation definition of spitting, right? Anytime saliva is propelled past the plane of their lips, right? So you can get a nice definition and create definitions that may arise that may not have been accounted for, which is always a possibility that new behaviors come up that we haven't seen. Okay, data collection practice. What time are we at? Break now or keep going? We can be democracy today. Break, keep going? All right, let's do it. So, data collection. Everyone should have their data collection sheets. There's me. There's my daughter. I couldn't use any of the clinic data, so my children were my guinea pig, which they love to be. They were very excited, and they all couldn't wait to be able to be the first person to be fed. So this is very exciting for them. Now they're going to think that they're famous, but I will not put it on YouTube. Don't worry. So this is my middle child. What I want to do, you sort of see the maroon spoon. Those are the spoons that we generally use. There's pictures of them later on. My protocol is not perfect, and I'm going to tell you why. Because I had my two other kids and my husband all laughing at me while I'm doing this, and they were driving me crazy, and I couldn't take any more takes anymore. So you'll see what it looks like to do a mouth clean check. You'll see all those different things. And what I want us to do is take data. Hold on, I think I have this cool thing that I'm supposed to be able to do this. Aha, maybe? Yes. Okay, so we are going to take data. Everyone has a data sheet? Yes? If you need a data sheet, raise your hands. Yeah, there should be on that back table. Do you mind? And does everybody have a pen? Let me see if I have a pen. So we're going to practice taking some data. It's going to be exciting. All right, so right here, if you look here, we have our 5-second acceptance or IVGP. This is, I think, maybe my last daughter, I think, is doing a self-feeder. So for self-feeder, we're either going to put a check mark, 5-second acceptance occurred, or no, it did not. All right? Then we have our expels. If you want to put the number, you can, or you can just put a check, or you can put the number out there, right? If you can count them, that might be helpful. Generally, I don't start out by counting. Usually, I just start out with occurrence data. And if I need to, if expelling really is a problem, then I'll sort of like up my data collection ante. But it's may not be worth my extra time or effort to be able to do that. Then did the child pack, yes or no? Mouth clean, yes or no? If you have a mouth clean, you can't have a pack. If you have a pack, you cannot have a mouth clean. They're mutually exclusive. Was there any gagging? You can put the number or you can put a check. Were there any CIs? Again, those combined inappropriate behaviors, pushing away the spoon or turning away. And then was there any crying? Yes or no? 3-second onset. Ah, then it's a yes. All right, so we are going to take data on my lovely daughter, Eliora. Also, I will say there is generally a 30-second interval between each bite presentation. Okay, so you take that bite, 30 seconds, and then you do that mouth clean check. I didn't want you to have to wait 30 seconds. I thought that'd be super annoying, especially for just practicing data collection. So there's not 30 seconds in between. Let me get my paper. All right, is everyone ready to collect data? Who's excited? Right, so it's an example of giving nice interaction.
Good job swallowing. Excellent work. Take your bite. Good job taking that bite. Take your napkin. Send your pictures. Show it. Show me. Good job swallowing, Ellie.
All right, so what do you have so far? Rapid acceptance, 5-second acceptance, yes, 2 of them. Mouth cleans, yes, 2 of them. 16. All right. Oh, I didn't do a math clue check in the last one. What did we get? How many 5-second acceptance did you get? 5. Mouth cleans. 4. I didn't check on the last one. See? Trick. You don't know if she swallowed if I didn't check it. All right, so she got the easy one. Who's next? Let's see. No? Is that the one I just did? Hold on. Where are we? All right, data collection practice. We did that one. Hold on. This is the second one of her. Let's see. All right, everyone ready? Number 2. And go.
Good job taking that 5.
All right, was that 5-second acceptance? Who thinks yes? Who thinks no? All right, was there anything else you saw? CIs. Now we have to go back and see if that was 5-second acceptance. Ooh, where'd she go? All right, so let's take that. 1, 2, 3.
Good job taking that 5.
All right, next bite. Here it comes.
Take your bite. Good job taking that
5-second acceptance.
Good job taking that 5.
I should have said good job swallowing. Everyone's laughing at me. Sorry.
Take your bite. Good job taking that 5. I love it. Show me. Good job swallowing. Excellent work. Take your bite. Good job taking that 5. That was so fast. I love it. I really like when you take those bites so fast. That was awesome. Show me. Good job taking that bite. Take your bite. Good job taking that bite. That was also so fast. You're so good at this. You must love applesauce. Show me. Good job swallowing. Take your bite. Good job taking that bite. Show me. Good job swallowing.
Okay. How many rapid acceptances did we get? I'm getting very nervous about the people answering from my clinic over here. How many bite presentations were there? 6. How many of those were rapid? 5. How many of those were more than 5 seconds? 1. How many CIs did you see? How many refusal behaviors did we see? 1, 3. All right, we got to watch it again, guys. Let's go through and I'll scream out when I see one. Hold on, where am I? Second one. All right, CI. 1.
Good job taking that 5.
2.
Good job taking that 5. That was so good. Show me. Good job taking that 5. Excellent work. Take your bite.
CI?
Good job taking that.
No CI. She just didn't accept it.
Show me. Good job swallowing. Excellent work. Take your bite. Good job taking that bite. That was so fast. I love it. I really like when you take those bites so fast. That was awesome. Show me. Good job taking that bite. Take your bite. Good job taking that bite.
CI?
So fast.
No.
What is this? You must love that.
She hates that I say that. That's why I'm saying it.
Good job swallowing. Take your bite. Good.
I don't know what she was doing. I was waiting for her to do something.
Good job swallowing.
All right. How many CIs? 2, right? When she was holding it right there, she wasn't turning her head and she wasn't pushing it away. All right? That problem behavior would be reflected in our data for 5-second acceptance. Okay? So if you're looking at the percentages, let's take off that last byte because I hate doing percentages with 6 bytes. But if we were to, and that's why there's, if you look at the, you'll see that there's 5 bytes and then an empty line and then 5 bytes and an empty line. So you can calculate your percentages, right? So for that first session that she did 100% acceptance, and she had, well, I didn't check the last one, 4 out of 4 mouth clean, so that's 100% mouth clean. Did she swallow all the bites here? Did she, good job swallowing? Yes, she did. She swallowed them all really nicely. So if we take off that 6th one, because I don't like calculating out of 6, I like calculating out of 5, she had 4 out of 5 rapid acceptance, so 80%, right? She had 100% mouth cleans, and then she had 40% CIs. Okay, so that's how we can then check across sessions, how are we doing? Are we going in the right direction, or is it going in the wrong direction? All right, let's take some more data. This is my son. He wanted to have the fun session, so this is the fun session. Giving you a little foreshadowing here.
Good job taking that bite. Oh, that was so good. Nice work. Show me. Good job swallowing. Take your bite.
He's so cute. I'm sorry, he's so cute.
That was a really good job. Nice working, dude. Show me. Good job swallowing, bud. Take your bite. Good job taking that bite. Nice work. I like the way you took that one so fast. Show me. Good job swallowing. Take your bite. Good job taking that bite.
He's so happy with himself.
Take your bite. Good job taking that bite, bud. That was really
I didn't know if he was going to spit or not, whatever.
Nice working, dude. Show me. Good job swallowing, my friend. I love that one. Last bite. Take your bite. Good job.
Okay. I told you this is a good one. He's so cute. I love him. How many 5-second acceptance did you get? What was your percentage? No, that was 5. It was 6? Oh, I missed one. Shoot. All right. We'll just go by consensus. How many times did he accept rapidly?
'Cause you represented after the first fit, so I count that as the second trial.
All right, we're going to go through this one again, and we'll call it all out together. How many expels did he have? 2. How many mouth cleans did he have? 4 for all the ones that I checked. I skipped some, sorry. How many CIs did he have? 1. Okay, so let's look at this again. All right, let's look at this again. All right. 1, 3, 2, 3, 4. Okay, so let's count it again. 1, 2, 3. It's real seconds. So that was 5-second acceptance. Now here's the bite presentation. 1, 2, 3, 4, 5. Greater than 5-second acceptance. And CI.
That was a really good job. Nice working, dude. Show me. Good job swallowing, bud. Take your bite. Good job.
5-second acceptance. No problem behavior.
I like the way you took that one so fast. Show me. Good job swallowing. Take your bite.
5-second acceptance. Expel. And that's when I'm not giving him attention, right? You see that I divert my attention from him.
Take your bite. Good job taking that bite.
5-second acceptance, no problem behavior. So he loved. Oh no, we took a few practice runs. Trust me. So the important thing also is that after that expel, I didn't do a mouth clean check because he wasn't going to mouth clean, right? So there's no mouth clean on that one. So if you don't have a mouth clean, it's either because there's an expel or there's a pack. Does that make sense? Go ahead.
No, I was just gonna say, like, how long do you wait before, because you spit like a couple seconds after, but if you go ahead and say, good job, right after.
Right, so did you hear that I stopped mid-sentence? Usually I say, good job taking that bite. Here, let's watch this last. That's mid-spit, right? There you go. There you go. He's getting ready to spit it. Right, so I stopped my praise in the middle. I was about to say, good job taking that bite, but when I saw that spit, what you don't want to do is a kid spitting, you're like, good job taking that bite. No, right? Then you're praising the wrong thing. All right, and now for the most complicated one. Good thing I have 3 kids. Otherwise, you would have gotten bored with the same kid over and over. So this one is a self-feeder protocol, right? So we'll go back to that IVGP acceptance. Did she take it on the independent when I put it out? Did she take it after the verbal when I said, take your bite? Did she take it after the gestural when I said, take your bite like this? You do it. Or did I have to physically guide her to take that bite? Okay, so we'll take and again, if you look at the top of the sheet, you'll see it's either 5-second acceptance or IVGP. Okay? Oops, sorry. She's trying to be really mean and really angry. All right, so it was a fun night in the Lisak household a few nights ago. We had a great time. So the question is, let's go through the acceptance first. Was bite number 1, I, V, G, or P? I. Next bite. G. Next bite. P. Next bite. Good. Next bite. Good. Right? So now in terms of sort of success criteria, that would be 80%. Because the only one that really only counts as non-success is the physical guidance. Everything else she took differently. Now, I didn't take data on grimacing, right? She was put on her actress. She was in her actress. This was the nut allergy girl. She's the drama queen. But we could have taken data on grimacing, right? If we feel like, and there are times when I see no problem behavior, but a kid's like this. Everything else looks good. He's taking the bite. He's not having a CI. He's opening nicely, but clearly he is not habituated to that task. Because every time it goes in his mouth, he's just like, so do I want to move on at that point, yes or no? We could take data on something else like grimacing, right? To be an indicator of, is this child ready to move on to the next step? All right, how about any CIs? Did you see any CIs? There can only really be a CI with that physical presentation, right? When I was physically guiding her up, did she let me do it, or was she doing this? She was doing this, so that's the only CI, the inappropriate behavior we're going to have. Because otherwise, she was taking it herself. So even, I guess, if she's doing it herself and going like this, that's not really CI, because I don't think I would count that as CI, because she's the one doing it herself. I guess I've never really conceptualized it that way, but that would not be a CI. It's only when you're physically guiding, is she pushing against your hand, right? Or is she doing any of that? Go ahead.
When you present the food and she has the, before she grabs it.
No, because it's only, the CI is only counted during that bite presentation. All right? So that's a good question. But if we look back at the operational definitions, hold on, where's our CI? Right, it's only during the presentation of the bite or drink. Wrong one. It's only during the presentation of the bite or drink, right? Not during that mouth clean check, or not even when the spoon's out. But again, if there are other behaviors that I'm seeing that would indicate that there is still non-habituation to the task, or she's not successful at that task yet, we can always add additional operational definitions to be able to incorporate into our success criteria. Does that make sense? All right, everyone's expert at data collection? Yeah, go ahead.
I just had a question. When you did, when you had to go to the second step, when I did, when you
Uh-huh.
you didn't reinforce her. You kept it quiet.
Which part? Oh, when I guided her? Correct. So, because that's not a very good job taking that bite. So correct. So I guess these are things I don't even notice because it's so automatic. That you give praise, very nice job catching that. You give verbal praise after an independent, a verbal or a gestural prompt, but if you have to physically guide, that's not a good job. If I'm gonna give you honest feedback, that was not a good job taking that bite, right? So that's where that reinforcement contingency comes into place of what behaviors are you trying to reinforce? Now, as we know from the last section, does attention in and of itself affect feeding behavior? No, but it's still a nice thing to do and a nice thing to let a child know when they do get it, right? And you saw just similar to when my son was spitting out the food, right? I didn't sing. You can't play, bud. But when he did, we were plating, we were chatting, we were singing, wheels on the bus, 5 little monkeys, high fives. Those are all sort of the social pieces that we'll put into play based on appropriate feeding behaviors. But if there's inappropriate behaviors, sorry, bud, you can try again the next bite. You have 30 seconds and you can try it again. Any other questions on, go ahead. Yeah. The side? No. Right. Right, so when the first time when there was problem behavior, I still said, good job taking that bite after they accepted it, because I was praising acceptance, not necessarily contingent on problem behavior. But then if they didn't take it quickly, right, I still praised after they took it, even if it was 7 seconds, because I'm still praising that acceptance. But the next time, you're right, I then said, great job doing that so fast. That was a really good job, right? There is a differential praise going on based on the behaviors that I saw previously and the behaviors that I see next, right? So when he kept that bite in his mouth, that's when I would say something like, I love the way you kept that bite in your mouth, bud. That was excellent, right? So you can absolutely differentiate your praise and your attention to let them know exactly what they need to do and how you want them to do it. Especially if you see a whole string of, problem behaviors or extended, non 5-second acceptance, and then you see a quick one, absolutely you want to differentiate that. So yeah, so those are things that I think I don't even notice anymore, because it's just such, after you feed, I don't know, 10,000 bites at this point, maybe 20,000 bites, it sort of like just becomes a rote. But you're right, that there should be a differential attention for that.
Do you pick up your pace depending on the child too, or do you always wait the 30 seconds?
Generally, I will wait the 30 seconds, because again, if we're conceptualizing it as an escape-based function, the break acts as an escape, right? If you want escape from this, you're going to get 30 seconds of no food after taking that bite. So then you can get a break, right? So it's always important that whenever there's a function of behavior that is maintaining a behavior, if it's escape, right, it might be appropriate to escape a task like brushing your teeth, right? If a child hits their parent because they don't want to brush their teeth, because they don't want to do it, what happens if that child had said, "Mommy, can I just brush my teeth in 2 minutes, please?" Yeah, okay, that sounds fine. That's not a problem, right? It's not that the function is inappropriate. It's the way you're trying to get access to that function. If you want a break from the food, there's totally a way you can get a 30-second break. Take it really quick, swallow it, and you get a break for 30 seconds, right? Same thing with access to attention. If you want your mom's attention when she's on the phone, you could absolutely kick her in the shin, right? That could work, because she's going to hang up the phone and give you a whole bunch of negative tension. You also could say, write a note and say, "Excuse me, Mom, I have a question. Can you put the call on hold for a second?" Any parent would be like, "Yeah, oh my gosh, of course, why not? Yes, right?" Or instead of grabbing a ball away, if I want that ball, that could be an appropriate function. I want, tangible function of that behavior. I could either grab it from someone else, or I could go up to that person and say, "Excuse me, could you think I could get a turn when you're done with that?" Yeah, sure. So it's not necessarily that the function is inappropriate. It's that the way of going about meeting that function oftentimes is when we see the problem behavior. So that's why it's important not just to extinguish problem behavior, but to replace it with a functional, more adaptive behavior, right? I don't just want refusal behaviors to go away. I want pro-social feeding behaviors to increase. So it's both sides of those coins, not just making one thing go away. And anytime we're trying to extinguish any behaviors or get rid of any problem behavior, it's absolutely incumbent on every therapist to find a replacement behavior for that child, because they're communicating a need, and that need is not inappropriate. It's how they are communicating to gain access to that need. Does that make sense? So that's why when we're talking about a function of behavior, if the function is escape and you want escape, right? I'm using want, sorry guys. You want escape, you can have escape, take your bite, and then you get a break. No problem, right? Now, that's when we first start treatment, right? By the time it gets to the end, right, and children are being discharged, they're sort of eating at their own pace. Or maybe every once in a while, the parent just sort of has to give them a verbal prompt. "Hey, bud, time for your next bite." Right? It's that structure really has been, that scaffolding has been taken away in a slow, deliberate, thoughtful manner. But the structure at the beginning is very clear and very precise. So the kid knows that when that timer goes off, time for my next bite.
So you're actually setting a 30-second timer.
I'm actually setting a 30-second timer.
And during the 30 seconds, especially if it becomes awkward, are you conversing?
It depends what reinforcement contingency is in place, right? And we'll talk about the different reinforcement contingencies in the last section. But for some kids, I'm chatting and we're talking. For some younger kids, we're singing and we're doing Wheels on the Bus. For other kids, I'm not saying much because they want me to shut up so they can watch their video. Depends. It totally depends on each child. Yeah, go ahead. Oh, yeah, absolutely. right? For children who are able, and we'll talk about sort of programming and choice also, right? For children who are cognitively able and developmentally able to understand what's going on, I would much rather explain it to them, right? Let's use the skills that they have, and I'd much rather give them a choice of some of the treatment options, and we'll talk about how to do that. Absolutely. Question?
I was just wondering if this is a typical.
These are our data sheets. That's a data, this is a data sheet we used in our session.
30 trials.
Well, I didn't make it double-sided. Usually I would say that we get through 8 to 10 sessions in a 45-minute appointment, if a session's going well, right? And depending on the reinforcement contingency and depending on a bunch of things, that we should be able to get in about 40 to 45 bites in a session. Again, if you're thinking 30 seconds, depending, right? Then you talk about the mouth clean check. Show me like this, say ah. Show me, there's another 20 seconds that you lose. So at least one a minute, for about, depending on how much problem behavior, depending how long it takes a mouth clean check, all that kind of stuff. But in bringing the family in, ending the session, I would say that if a session's going well, on a good day, we'll get in 40 sessions. And we'll talk about, and not all those 40 sessions are the same thing. If things are going well, we're making changes throughout the protocol, right? And we'll talk about what a success criteria look like and when do you move on, all that in the next session. Go ahead.
Do the parents bring the food?
Yes. Different clinics do different things. In Atlanta, there's a huge pantry, and we make all the food. We made all the food, or I didn't make it. The therapist made it. All the food was made at there. And there's pros and cons to both. We could talk about that. The pro to having the food made in the pantry is because they buy the exact same brands every single time. So the chicken is always going to take the exact same. The corn is always the exact same brand of corn. There's definitely children that I have seen where they ran out of that corn, so we bought the other corn. They're like, no, this is brand new. not doing it, right? So the good news, the pro for that is that it will always be the exact same every single time. The con of that is it's a lot of labor to have people preparing food like that to that extent all day for a very busy clinic. The other side of the coin is if we're having, what I've actually really appreciated is having parents bring in food, is if we're starting with something new anyway, we can start with foods that the parent actually makes and is flavored according to what the parent actually does, right? So I've actually liked that piece of it a lot more, being here where we have parents bringing their own food, so that from stage one, if they're getting used to black beans, right? We're not talking about black beans out of a can. We're talking about good Cuban black beans, right? Because that's what they have to get used to anyway. So if we're going to get them used to something new, why do canned black beans and then get them used to the parents' Cuban black beans? Let's get them used to so there's definitely both sides of the coin, because even though grandma uses the same recipe to make the black beans, it's always going to taste a little bit different. So kids who are super picky may have a different, there could be some differential response based on 1 week's worth of beans versus the next week's worth of beans. So that's a con side of that. So you have to play out sort of both ways. I've happened to really like parents bringing in the food. I just think that it has helped transition to home a lot quicker, but there's both sides to the coin. Any other questions? Yes, Dr. Wilson.
Another pro and con I would say too, just from doing both, is that if you prepare it yourself at the clinic, you're always going to get the right texture. You know what you're looking for.
Yeah, that's true. Yes, so that's a good point too. Puree is hard.
But if you are asking parents to bring in, as you go through, you can teach them how to do it. You can say, look, this is a little too thick. I took it to the pantry. I blended it up a little bit. This is what I want it to look like next time. So you're kind of parent training them in the process, which I think is helpful. If you were to send it home, they already know what to make at home.
Yep, absolutely. Absolutely, thank you, good point. Or if you want it chopped a certain way, if you're doing, I would say if I'm doing a real texture fading protocol, like really going from puree, and we'll talk about this, puree to wet ground to chopped to table texture food, I might just have them bring it in and I might prepare all those different textures if I'm trying to do an assessment. But generally it's worked where they get to bring in their own food, and I've liked that a lot more.
Do you then work on one
We're going to talk all about that in the next part. Yes?
So when the parents are home with the children, do you expect them to kind of keep track on like if they're doing outcomes or like
After I train the parent, yes. Right? And we're going to talk about what parent training looks like. After a parent leaves our session and after a parent has been trained by us, they could come back and be hired as a feeder. That's how good they are. But initially, when we're at this stage, right, where any of my kids at that stage, parents don't do anything at home. In fact, you know, parents will say, "Oh my gosh, she just ate applesauce for you so well. I'm totally gonna give him applesauce at home." And I go, "Let's wait a second, okay? Hold on. What I'm gonna say is this: if he would like applesauce, allow him to eat it on his own terms. If he says, 'Can I have applesauce, please?' Give it to him. If he then says, 'I'm done with the applesauce,' you say, 'Okay.'" Again, I don't want them, right, if I go through, you know, an extinction burst where the child was, you know, it was taking 5 minutes for them to take one bite, it went down to 3, it went down to 1, and then we get really good 5-second acceptance, and then the parent goes home and tries the same thing, and they don't do the same protocol, they're going to reinforce problem behavior at a higher level, and then I got to go over it again. So I usually tell parents the good news is this: you don't have to worry about what they're eating anymore or how to get it done. Hopefully the good news is now it's my job to do that, right? A lot of parents are like, "Oh, thank God," right? So I say, like, so dinner should look like this. "Hey, bud, what do you want for dinner?" And that's all they have to do, which for so many parents, it's like, thank you, that I don't have to worry about this anymore. Now, again, I want to be very clear that it's because that I'm not concerned about any acute nutrition concerns, okay? That if the kid's going to eat veggie nuggets, all right, they've been living off of veggie nuggets for the past, 2 years. Can we get them off it, give us a few, 3 months, and hopefully we can move past that. All right, we're going to take a 10-minute break, be our last break, and then we'll go in for like the kill of all of the really good things about what to do. Okay, so the last part we're going to speak about is really, okay, I've talked about everything at this point except what to actually do about it. So we're going to talk about what to actually do about it and do about feeding behaviors, feeding concerns. So to begin, I want to make sure that I, nod my head to our 4-term contingency. If you're not familiar with this, it's really looking at behavior through our ABC lens, including sort of the background of motivation of what's going on. So when we talk about motivational operations, especially with feeding, hold on one second, sorry, I want to make sure I get this on the right view. So when we talk about motivational operations, it's important to think about how this regards to food, right? So a motivational operation is sort of the background, sort of setting the stage for what happens in a behavior. So for example, if I just ran a marathon, water is going to be very salient to me. I'm going to want a lot of water. If I'm in the middle of the desert, water is going to be something that I am motivated to gain access to. If I just drank a gallon of water, my motivation to drink water is going to be decreased. So the same thing for food. It's important to think about if a child has eaten immediately prior to session, is that child going to be hungry? Probably not. Now, do I think that you should starve a child before the day of a session? Absolutely not. But just to be aware that if a child just ate some food, it may not be the best opportunity. So I usually ask parents to restrict food, an hour, hour and a half prior to session. Now, the beginning of session, when we first start treatment, they're not getting much nutrition in. So it may not necessarily make a difference, meaning that we're starting with such small amounts and such easy tasks. The volume of food that they may be getting during that time may really not be critical in terms of are they hungry or not. It's just sort of that exposure and that flavor exposure. But once children start to eat a larger amount of food during session, be aware that it could be an important factor to consider of asking parents to not feed the child for a certain extent prior to a session. Or if you know the child has lunch at 12 o'clock at school, don't have them come in for a 1 o'clock session, because they just may not be hungry, which is totally appropriate. If a child's not hungry, they shouldn't be eating more food. So that's motivational operations if you're not familiar with that. Otherwise, when we talk about behavior, we have our antecedents, what happens before the behavior occurs. We have the behavior, and then we have the consequences, what happens after that behavior occurs. So there are going to be interventions that address both sides of the equation. Interventions that we can put in on the antecedent side prior to the feeding behavior happening, as well as consequences that we can put into play after, in response to feeding behaviors. And again, the behavior that we're focusing on is accepting, maintaining, swallowing that bite with low problem behavior. Those are the behaviors that we're really talking about. So in terms of our antecedent strategies, and we're going to go through all of these in a pretty comprehensive way, we can fade in different stimuli, like a bolus. Bolus is the amount that you have on the spoon. You can fade in non-preferred foods. You can fade in different texture, and you can fade in by blending. And we'll talk about all those different strategies. There's also a presentation modification. There's different ways that you can present food to children using different utensils, which we'll talk about. And then you can also just have non-contingent access to a preferred environment, using the opportunity to enrich the environment with something fun, maybe something distracting to help prior to any problem behavior or pro-social behavior prior to any behavior occurring. So the first thing we'll talk about is bolus fading. So the smallest amount that we generally talk about is a rice-sized bolus. So this is a large maroon spoon. Those are generally the feeding spoons that we use for a few reasons. One is because you don't want like a metal spoon that may be like have a sharper edge, or a plastic spoon that has a sharper edge. This has like a nice, thick, rounded lip that isn't going to really, hurt a child in any way if they, turn their head quickly and brush up against it. So one of the issues is safety. And also, I was just doing this with the girl, I think I was trying with my children at home. They're my guinea pigs. And we were using a plastic spoon. And a plastic spoon has a very deep bowl, right? And those are really hard to work with. So this actually has a little bit more of a shallow bowl, which makes it a lot easier, especially for children who may have a skill deficit, to be able to work with. So I generally start with this type of spoon. There's also a small maroon spoon, which is small, for children who might be younger or smaller or have smaller mouths. So you can do the same thing. So when we talk about a rice-sized bolus, it's really a grain of rice. Think of 1 grain of rice. If it looks bigger than 1 grain of rice, it's not rice size. Really make it small. Make it easy. Then the next we have is 1 pea. Remember our famous pea? It's about a 1 pea bolus. If you think of 1 pea pureed down, that's what it looks like, again, from the aerial view of my kitchen and from the side view. And then 2 pea. So 2 pea is generally, when you look at most of the literature, sort of where you start. It's about 1/4 of that spoon, 1/4 of that large maroon spoon. And it should be pretty flat. Then we have half level. Again, a nice flat half of that spoon. Level, the whole spoon as flat as possible. And then rounded. Generally, I only do rounded with children who have a volume concern, right, where we're trying to get a child off of a G-tube or get them off from formula to solids, and generally only use it at a pureed texture. I wouldn't use a rounded spoon for table texture. That's just a lot of food on a spoon. I wouldn't go past a level bolus. So part of talking about where are you going to start with the child is identifying what bolus are you going to start with. Oftentimes, I just start with right size. Make it easy. Find the easiest opportunity that you can to find success with the child. So, and then slowly and then systematically fading up based on success. And we'll talk about what success criteria looks like. But if you're successful at right size, go on ahead and go up to 1 pea, go on and go to 2 pea, half level, level, and again, if we're talking about a volume kid, potentially rounded at a puree texture. Now, why is this so hard for parents to do? Because some parents, and understandably so, are like, really? Really, a rice? Really? You're joking me. I know he could do more than this, right? That's why you need someone who's a professional who's going to really follow that slow and steady pace of what success looks like and keeping it nice and steady. Or I'll see parents say, all right, great, he did great with that like small amount of the spoon, let's just go up. No, that's why we have a procedure, and we're going to go nice and slow. So that's one of our antecedent strategies, to be able to start with a small bolus, and based on success criteria, we'll talk what that is, systematically move up. We also have an option to fade in non-preferred food. So say that our preferred food is Cheetos, hence the bright orange color, right? You may want to start with the child where they can have Cheeto, 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 Cheeto. 5 bites of Cheetos, because I want to make sure that they'll accept that non-preferred food. I want to make sure that they're going to accept the preferred food from me. So we'll start with just 5 bites of Cheetos, bud. This is super fun. Cheeto, 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 Cheeto. Cheeto, 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 Cheeto. Right? And thinking about what bolus that might be. Generally, I'll do a larger bolus for a preferred food. And then, next step, 1 out of 5, we're looking at some banana. Cheeto, Cheeto, right-sized amount of banana. Cheeto, Cheeto. Cheeto, Cheeto, right-sized amount of banana. Cheeto, Cheeto. Right? After I'm successful there, Cheeto, Cheeto, banana. Right? Cheeto, Cheeto. Right? And especially if you imagine these are some kids who are probably zoning out, watching a DVD. They're eating their Cheeto. They're eating their Cheeto. Banana. Cheeto, Cheeto. Right? You get a little bit of a, but they're super into Thomas the Train, so it doesn't even matter. Right? That again, if you're decreasing the response or the phobia response to some of those, what if you're focusing on it, really intense behaviors, and you can get them just sort of responding and getting them used to some of those new flavors in a slow manner. That's what this does, right? So after success here, what do? Cheeto, banana, banana, Cheeto, banana. Cheeto, banana, banana, Cheeto, banana. Cheeto, banana, banana, Cheeto, banana. I think I skipped a step. I think it's supposed to be 2 non-preferreds. And then, but that's okay. We skipped a step. And then, did my colors not work? 1, 2, 3, 4. Green. There should be a yellow somewhere. I'm sorry. What happened? There should be another one of these. So we should have Cheeto, banana, broccoli, Cheeto, banana. Cheeto, banana, broccoli, Cheeto, banana. Right? So once we got banana on board, and that looked good, we'll add in our second non-preferred. All right? So now we'll have 2 preferred, 2 bites of non-preferred 1. Sorry, this is supposed to be banana, banana. And then 1 bite of that new non-preferred. All right, now we have our, this is chicken, thank you. I was like, I knew it was something. Cheeto, banana, broccoli, chicken, banana. Cheeto, banana, broccoli, chicken, banana. Cheeto, banana, broccoli, chicken, banana. Right? You do that a few times. And again, all these non-preferred foods should be at a rice-sized bolus. Again, really small, really easy. And then finally, we have Cheeto, banana, broccoli, chicken, and purple something, like mashed potatoes. Purple mashed potatoes. Okay? It made sense when I was making it. I don't know why I forgot all my foods. So then that's the way you can fade in, have a nice fading procedure of slowly, incrementally adding in a new non-preferred food at a very low, easy bolus while still having some preferred foods in the rotation. Another antecedent strategy. Fading texture. Right? For those children who may have the skill to chew and are choosing not to chew, we may start with a really easy texture first. Right? We'll start with sweet potatoes at puree. Right? Make sure they're getting that flavor exposure. And in fact, sometimes even for children, especially on the spectrum, for children who I know can chew, there's no texture concerns at all. It's more of a selectivity by type concern. I may start with puree anyway, because if you think of it, if you put a piece of broccoli in a kid's mouth, what are they going to do? Spit it right out. You know how hard it is to spit out every single particle of puree? Hard, right? So if we're just talking about texture, if we're just talking about flavor exposure, get those particles on their tongue, because if you want them to taste something, it has to actually get on their tongue. So if you're using a puree texture to begin with, even if I know the child can chew, we're just basically doing flavor exposure. So you can start with a much lower texture of food to get that flavor exposure and then fade up the texture. So for some kids, you have to go through every single phase and every single step of the texture. Some children, you can just jump. So you go from something like puree to applesauce, which is just generally like a wet ground. So if you think of it, applesauce is gritty, right? It's got something to it. Then you go to something like a ground, which is breadcrumbs, right? Now, you can't really get, I don't, right? But if you think of not, I'm giving an example of the texture, not the food. How about that, right? But if you're thinking of chicken nuggets that you sort of ground up, right? Or if you're thinking of string cheese at a texture that's that's ground up. Again, an easier texture for them to get used to. This is texture fading up the scale. And then the next one would be chopped, which is sort of like minced garlic. If you think about it, just minced and chopped super, 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 super fine. And then we have our table texture. So these are really all the levels of different textures that we can get a child accustomed to. Now, say I have a child who chews everything just fine, but I started with puree food just to get that flavor exposure first. say they are now at a level spoonful for all those foods, right? They'll eat all those pureed foods now at a level spoon. I have to now increase the texture, so I may do a texture assessment to see what are they going to do well at. So maybe we'll look at puree to keep our control in. Maybe I'll go to like a chopped and a table texture, or a ground and a table texture, and sort of compare those three textures and see, can that child make a jump a few steps? There's some children I have to go through every single texture to get them up to table texture, okay? Because of the rigidity and getting used to every new thing in a very small incremental way. But texture feeding is a way of getting that texture up. Again, for children who have the skill to chew. Blending. There's a plus side and a negative side to blending, but we'll talk about what it is first before we talk about the negative side to it. So say, and blending is mixing the ratio preferred food to non-preferred food. So for example, say you want a child to begin to drink water and fade out their juice. This is sort of, it's an easy to think about with liquids. So you can start with, they drink 100% juice, then you can go down to 9 parts apple or applesauce to 1 part pureed chicken nuggets. Yes, we puree everything. We puree peanut butter and jelly. We puree fish sticks. We puree everything that's out there. But say that there's a child who's doing chicken nuggets, who won't do chicken nuggets, but will eat applesauce just fine, right? You can go to 9-to-1 ratio of applesauce to chicken nuggets. 8-to-2 applesauce to chicken nuggets. 7-to-3, 6-to-4. And then 5-to-5, 4-to-6, 3-to-7, 2-to-8, 1-to-9, 0-to-10, right? Yes. What was the question? No? Oh, I thought you had a question. Right? So, but again, if you think about it with apple juice and water, you can think of this kind of ratio working out to get them off the apple juice and to be able to accept the water. Now, one of the problems with potentially using a blending intervention is the fact that if you taint their preferred food, they may not accept that preferred food anymore. So that's always a very important concept to think about, that if all of a sudden they won't take the applesauce anymore because it tastes too different, then maybe you just knocked a food out of a child's repertoire, which is a really important consideration to think about before you use this type of intervention. Does that make sense? All right, presentation modification. So there's different types of utensils that can be used, right? Like a nook brush, or this is a small maroon spoon. And so for example, for a child, there's a lot of children that will see when I deposit the bites, they don't close their lips on the spoon. And you sort of have to scrape it on the back of their teeth. And when you scrape food on the back of their teeth and they let it fall out of their mouth, it never touches their tongue. If it doesn't touch their tongue, they don't ever get the flavor exposure, right? So for some children, if they're really averse to having it touch their tongue for flavor, guess what you have to do? Get it to put it on their tongue, right? So there's a few different ways of doing that. One could be using a nook brush. I think if you don't need to use a nook brush, it always feels a little bit funny if you've never put one on your tongue. But there's also something called a flip spoon, which has been written about in the literature, where you take a small maroon and you just flip it on their tongue, right? You're wiping that chicken nugget all over their tongue. Usually this is exclusively for pureed food, right? They are getting that flavor exposure on their tongue, and that's an important thing to do. Now, for something like a flip spoon presentation, they may have to sort of think about, well, wait a second, he's probably not going to let me just do that. So before you put food on, you may want to do an empty flip spoon, right? Get them used to just that motion. And then you'll start with a right-size amount, flipping it on their tongue, flipping it on their tongue, and then bolus fade that way. But you may need to start with an empty spoon just to get CIs down or acceptance up in the easiest way possible with the least demand possible. And then non-contingent access to a preferred item. Right? This isn't a reinforcement procedure because I'm not reinforcing any problem. I'm not reinforcing anything contingent on behavior. They just get it's free play, free access. You get to zone out to your iPad while I am going to give you food. And that often works. what I find interesting, and you can always do a preference assessment to decide which is going to be the child's preferred item. If a child is verbal, you can give them a few choices. Hey, bud, do you want to play with trains? I got trains. I've got Legos. I've got an iPad. What do you want? Trains. Okay, here you go, trains. Or if a child is not verbal and can't really make those choices in the same verbal way, you can always, do a preference assessment where you give them a few choices and a few options. I have iPad. I have some blocks. Pick one. And if you do that over a few times, you can get a sense of which are they picking more often. What I always find interesting is I always give kids a choice. And for the children who choose the trains or the children who choose the Legos, I just had a boy that this happened to. He always chose the trains. And I was seeing really high rates of problem behavior. Not intense, but just rates of CIs. So at some point I just said to him, all right, bud, I'm choosing today. We're watching the iPad. What do you want to watch? Zero problem behavior from that point on, right? He was just zoning out. So it's important to be able to get these, if you're doing something like non-contingent access to a preferred item, you need to be able to know that you have to get it out of the meal at some point if parents don't want it. Or something like toys may be more socially appropriate for a 5-year-old to have at their table, a train or two to play with, than zoning out to the iPad. So there's sort of pluses and minuses to both sides, but just know that whatever you put in, you got to be ready to get out at some point if the parent doesn't want it in. Like I said, some parents will say to me, no, we all actually have our own iPad at dinner. Okay. Sounds fun. So, I go based on, and I try to feel out the parents of what do you want this meal to look like at the end of the day so I can start programming that in from the beginning. So now the consequence side. This is where we talk about our escape extinction protocols, attention extinction, non-contingent reinforcement, differential reinforcement, alternative behavior, and punishment, which hopefully we don't have to use very often, and if so, it's only just a response cost. I just hate that term. So to begin with, when we talk about going back to that research, those research articles, what is going to very clearly and distinctly change behavior? Escape extinction. So let's start there. If we talk about these behaviors that we talked about earlier and the disruptions that we talked about earlier, we have an escape extinction protocol for every single disruption that we see. Now again, escape extinction means that that problem behavior used to result in me getting out of the task. I took my mom presented the bite, I screamed, I didn't have to do it, right? That's in terms of, or the food was there, I cried, and so I left the table. I was given the bite, I turned my head, I didn't have to take the bite. I accepted the bite, but I spit it out, I didn't have to eat the food anymore. Or I accepted the food, but I just packed it right back here. Guess what? I don't taste it anymore, right? So there's an escape function for all of these problem behaviors, and there's an escape extinction protocol to address each one of these behaviors, and we'll talk about it. So for example, Alana brought up a great question. How do you prevent a kid from leaving the table? Well, you get a chair where you buckle them in, right? That's pretty, that's a pretty low-level intervention. So I would say for even children up to the age of 8, we have a Kikaroo chair, which is, if you've seen like those Stoke chairs or those Stork chairs, the Kikaroo one is a little bit cheaper. It's about $100, and it's the kind that with the moving foot pedal that it can seat up to an 80-pound child. So for larger children, for older children, I'll just take that and scoot that up to the table. Like I don't put the tray on. For younger children, I might put the tray on. But for the older children, for the first few sessions, I'll just buckle them in, and they, for the most part, don't have a problem with that. I'll ask the parents if it's okay, and the parents say, sure, it's not a problem, and they hop up on the chair, and they buckle themselves in, and they're totally fine with it. So there you go. They don't leave the table. Accepting the bite, right? If they're not accepting the bite, we're going to use a non-removal of the spoon protocol or that 4-step guided compliance protocol, and we'll talk what each of these look like. If the child's expelling the food, we're going to represent it. If a child is packing the food, one of the escape extinction protocols is we can redistribute it, right? And we'll talk about what that looks like. And if a child vomits, we do not feed children vomit. Let me be very clear. We do not feed children vomit. No one should ever feed children vomit. But I'll get a new bite and I'll continue with the meal. Right? Now, let me be clear again. If a child is vomiting because they're ill, stop the meal. Right? If the child is vomiting because they're trying to get out of a meal, clean them off. Don't let a child sit and vomit. Clean them off. Don't give them much attention. And continue with the bites. Right? So let's go through each of these. So non-removal of the spoon, right? This is a non-self-feeder protocol, which you were talking about, how do we decide which one to do? So if the child doesn't take the bite, you hold the spoon up to their lips till they take a bite, right? They're going to learn over time that if you want that food to go away, you have to take that bite. And then in a in a self-feeder format, I sort of showed you what that looked like. That you put it out on a plate, you give them a chance to take it, take a bite like this, you do it, and then guide them to take a bite. How do you decide between a self-feeder or non-self-feeder protocol? I usually leave that, generally I will say if a child is 5 or younger, 5 is like a little bit of a gray area. For sure 4 or younger, I'm fine using a non-self-feeder protocol. Unless a child really says, no, I'll do it myself. Okay, do it yourself. 5 is like that gray area where sometimes I will, sometimes I won't. But generally 5 and up, 5 and under, 5 and up, I'll go to a self-feeder protocol. Unless there are some developmental delays, right? If a child is delayed, I may still start with a non-self-feeder protocol, and I may feed the child. Again, as a step to get them used to the food with the goal that at the end of the day, they of course are going to be self-feeding, right? Again, when I think of what's my end goal, how many steps backwards do I need to start for the child to be successful? For some children, it's just going to be a lot easier if I feed them, and they're going to be more successful if I feed them than if I'm always trying to guide them and guide them and guide them and guide them. Go ahead. So again, it depends. So if I'm using that, again, this is in conjunction with those antecedent interventions. So it might start off preferred. Where can the child be first successful, right? Then it might start off preferred, banana, preferred, banana, preferred. Again, that's where it's really hard to tell you exactly what I do with every child. It's going to depend on the child, right? But I'm going to give you sort of like a menu of options that you get to mix and match based on what the child's profile is, what the parent preference is, what your clinician intuition is. But have I held a spoon up to a child's lips for 5 minutes? Yes, I have. And then what I will tell you is I will then take data on latency until bite acceptance to see if that goes down. Generally, within a session, I am not holding a bite up to a kid's mouth for 5 minutes more than a few times. Right? And then after 5 minutes, it goes to 3 minutes. After 3 minutes, it goes to 2 minutes. Or that's when I change my reinforcement procedure. Right? We'll talk about reinforcement procedures. If a child's not taking a bite, but they are having a grand old time watching that iPad, guess what? Pause. Hey, bud, I'm going to push play after you take that bite. Oh. And I still might use that in conjunction with the preferred, applesauce, preferred, right? So it's again, trying to figure out what menu of items is going to work best for this child, what combination. It's like a choose your own adventure, right? I have not found there to be a child. Look, parents will come in and say, he only eats brown and orange things. Well, that's because carbs are all brown and orange, right? But, well, great, he'll eat orange things. How about a carrot? Oh, no, he won't eat a carrot, right? Usually, if it's like a color thing, it's generally a starch thing that I have found over time. Like that autism diet is very bland. It's brown, it's yellow, it's orange, it's white, right? But if we're talking about cauliflower, that's white. Oh, no, that doesn't count as white. So that's where it's like, well, is it really a texture thing? Is it really a color thing? I'm going to go, it might be a little bit more of a taste thing, right? So, so again, there's a whole bunch of different tools in the toolbox that you can combine and mix and match to help whatever that, you got to figure out where is that child going to be successful for the first bite. Because once you get some behavioral momentum going and they realize that they're going to have a grand old time, I will honestly say, and I have some people who can maybe back me up, I don't, unless it's a more intensive kid, I really don't see problem behavior in our outpatient clients for more than 2-3 sessions. Do you agree? For the most part? I mean, and again, even when we're seeing problem behavior, it's in the beginning of the session coming in, but by mid-session towards the end, they've calmed down. So that's where the data is so important, right? Because I know as a parent, watching a child cry for 20 minutes is hell on earth. I absolutely know that, and I absolutely empathize with that. But that's why data is so important. Because if you have data to show mom that, look, he cried for 20 minutes, but look how great he did for the next 20 minutes. He totally rocked it then. And to a parent, a child crying for 20 minutes is the same thing as a child crying for 10 minutes. It feels the same, and I acknowledge that, and I talk about that with parents. But if I have the data to show them that they cried 20 minutes their first session, but guess what? On their second session, they only cried 10. That's huge progress, 50% better. That's why data is so important. And then guess what? By the third session, we're down to 5 minutes, and by the fourth session, I tell parents all the time, give me 4 sessions, they will be running to jump into that seat. And most kids, they come in the clinic, the doors are closed because I have my previous client and they're busting in the door to get in their chair. They know what to do. So that's why data is so important, because you can really take a look of, are you making a positive difference? And if I'm not, again, I better do something different. I better change something and make it different. That's my responsibility, and it's a huge responsibility that I take on with parents and with children when I undertake the task to treat a child. So I take that very seriously. Sorry, I got, so self-feeder, non-self-feeder. So it depends. Some kids will say, no, I want you to feed me. Some kids will say, no, I'll do it myself. Okay. For lower functioning kids, I tend to start with a non-self-feeder protocol. For higher functioning kids, I tend to start with a self-feeder protocol. Or I'll say to them, if you don't feed yourself, I'm going to have to do it. And they'll be like, okay, you do it. Okay, that's fine. I'll do it for a while, but we'll get you there. Escape extinction. So we talked about representation, right? So how do we put expelling on extinction? If you spit it out, you don't get out of the bite, bud. Now, if they spit it out and it's right here, I'll scoop it up and put it back in. I'll scoop it up and put it back in. Again, I monitor that very closely. If a bite falls on the floor, I do not represent that bite. Let me be clear. If a bite falls on my shoe, I do not scoop up that bite and put it in. Just get a new bite. Just get a new bite. That's okay. But again, we have to teach a child that spitting is not going to be an effective means of getting out of that task. And again, copious data is really important. If you have a child who is spitting continuously, move from occurrence data to frequency data. Okay? Because it is a meaningful shift if you have a child who on average is spitting 10 times per bite, and that moves to 4 times per bite. That is progress. That means your intervention is working. If you go from 4 times a bite to 2 times a bite, 2 times a bite to 0.5 times a bite, that is meaningful progress. That means your intervention is working. That's why data is so important. And then redistribution, right? So packing for a lot of children is a way to get out of the flavor on their tongue. So where do they pack it? On the sides so that it is not on their tongue. So what do you do in redistribution? You take a little spoon, one of those baby-coated spoons, you scoop up the food, and you put it back on their tongue. Right? They don't get out of that flavor exposure. It happens again. You scoop it up and you put it back on their tongue. And that's what redistribution does. It's an escape extinction procedure for packing. Attention extinction, right? We also want to address the attention component and the attention piece of what's going on. Excuse me. So just like you saw with me in the video, attention can be number one, when we talk about the function, it can be an underlying function of the problem behavior during meals, but also it's just the normal social environment that should happen during a mealtime. This is a part that I think is important because it automatically programs in for social interaction and social connection, right? So you provide positive attention for appropriate behaviors. Great job taking that bite. Great job swallowing that bite. I like the way that you did that so quickly. I like the way that you are keeping that food in your mouth. Nice work, bud. Telling them what they're doing well. Oh, look, there it is. Playing and singing in between bites and after bite acceptance, right? If you think about what you want a meal to look like, it'll have a lot of what you would normally do with a 5-year-old when you're sitting down for a meal. Chatting about their day, talking about those, their favorite animal, whatever it might be. And then again, you're going to ignore inappropriate behaviors. If a child expels, right, telling them don't spit that out, probably not going to work, right? So you might as well just ignore it and not give them any attention for it, right? A child spits out in the middle of we saw a child spits out in the middle of the bite. You just stop that. Great. I was about to tell you, great job taking that bite, but you didn't do a great job. You spit it out, right? So ignoring all those inappropriate behaviors. I think ignoring inappropriate behaviors is the hardest part to train parents on. This is so hard for parents to do. I think within the feeding context and I think within the general behavioral context, ignoring problem behavior is so hard for parents because they want to reprimand. They want to tell their child that's not okay. Well, if it's not going to work, right? Let's take data. Does it work? No. So why are we doing it? Why are we giving them that attention? Because we could actually be shaping up a problem behavior based on inappropriate behavior, based on inappropriate attention. So stop all attention response to expels or packs. Restrict attention based on refusal behaviors, right? Exactly what we just talked about. There also could be a differential reinforcement of an alternative behavior. So what does that look like? That's where you have an actual toy in play, an iPad, some sort of tangible, an iPad, a toy, something that they actually have access to. And you can restrict that access based on the behaviors that you want to see. Okay? So potentially they only get that bite or that toy, they only get that toy after they accept the bite. That could be step one. Alternatively, they could then only get that bite after they take that bite in 5 seconds, right? So again, they could get the toy. If it takes them 20 seconds to take that bite, all right, you took that bite, here's your toy. But if you then want to decrease it from 20 seconds to maybe 5 seconds, then they may only be able to get that toy after that 5-second acceptance. Okay, so acceptance versus 5-second acceptance. Again, the easier one is acceptance. Once that looks pretty good, you may want to then bring it down to 5 seconds or incrementally. Maybe you start you take data, again, data, and it's taking about 20 seconds for them to take that bite. Maybe you then go to 15 seconds, then you go to 10 seconds, then you go to 5 seconds. I haven't ever really had to do it that incrementally with a child. But you may start with acceptance and go down to 5-second acceptance. Can you say that again? What's the question?
Like you said, okay, you go from 20 seconds,
Mm-hmm.
then you go down to 15 seconds, and then when it's down to 10 seconds, they stop.
You mean they don't take any more?
Yeah.
They don't get the toy. So that's a question of what does the data look like? And we'll talk about sort of when to make procedural changes, when to change your treatment. How long does it look like before you have to change something because it's not working? How long do you change something if something is working? right? When do you take the different steps? We'll talk about sort of what that looks like and what does consistent behavior look like. You can do a differential reinforcement of alternative behavior. So for a mouth clean, you swallow within 30 seconds. Here you go, bud. Here's your toy after you swallow. Right, that could be targeting packing. If they're packing the food, you could do that redistribution of doing an escape extinction procedure, or you could use a reinforcement procedure that they only get it after they swallow in 30 seconds. Or you could do a DRA for clean mouth. Now, clean mouth is when you swallow at any point. 31 seconds, 45 seconds, 2 minutes and 50 seconds, 20 minutes. Yes, there's some kids who pack for 20 minutes, right? That they get access to that only after they swallow. So you can decide, do you want to start with a DRA for clean mouth, then move to a DRA for mouth clean. Or other targeted behaviors that might arise. I've done a DRA for a child maintaining the bolus in their mouth for 5 seconds. Because when they kept it in their mouth for 5 seconds, they didn't spit it out anymore. Once it was in for 5 seconds, they swallowed. If they were going to spit, it was within those first 5 seconds. So I would count and say, you know, remember, after 5 seconds, you get to play with your toy. Good job taking that bite. 1, 2, 3, 4, 5. Here you go, bud. Good job holding that food inside your mouth. Here's your iPad. Right? So you could use a DRA procedure for a number of different behaviors based on what behaviors that you're trying to reinforce. Again, a reinforcement procedure should be focused on the behavior that you want to increase. So I wanted to increase acceptance behavior, mouth clean, swallowing behavior, or bolus maintenance behavior. Those are the behaviors that I'm focusing on because those are the behaviors that I want to increase with my reinforcement procedure. Punishment, right? Definition of punishment, anyone?
Administration that decreases behavior.
Someone's gonna pass their BCBA exam. Sounds good. So it's important to remember, I always like to do this sort of PSA announcement. The only thing punishment means is that behavior goes down. It's used in a lot of different contexts, but when BCBAs use it, they should just get a different terminology. I think that they should. It's a horrible term. But we're not talking about punishing the child, we're talking about punishing the behavior. And it only means that you want a behavior to go down. It does not mean that you want to hurt a child. It does not mean you want them to suffer. It just means that the behavior that you don't want to see should decrease. So the only really punishment that I ever use is a response cost, which means that if you have non-contingent access to your iPad, but you don't swallow within 30 seconds, I'm going to push pause. I'm going to take that, I'm going to try to decrease packing behavior. I'm going to punish packing behavior by taking away your access to something. So it's negative punishment. I'm taking something out of the behavior to decrease the packing. Or you can use a response cost for greater than 5-second acceptance. You can use a response cost for something else. But generally, you should use a DRA procedure first. Use a reinforcement procedure first, but there is this option out there. Go ahead? No. Someone told me, and I don't do this at all. So when I was working at Marcus, I met someone in the community that said, oh, my daughter went to Marcus. She still will not eat her Punisher food. And I go, what? What are you talking about? She goes, oh, when she was there, if she didn't take her bite of something, they made her eat her Punisher food. And I was just like, I don't understand, right? So apparently there are some other things that have been tried out there. We do not do Punisher foods. I think that's a horrible option. I think I've never needed to use a Punisher food, nor would I. I guess they would give her a bite of a food that she really, really, really did not like if she didn't take her bite. I just think that I'm clearly being judgmental, but I think it's horrible. That's really mean, right? So I said, we don't do that anymore. We don't give Punisher food. So the only punishment procedure I would potentially use and that I will try is a response cost, which again is a pretty logical consequence. You don't take your bite, you can't watch. You don't swallow your food, you can't watch. Now, again, we sort of talked about a bunch of different items here that it's really important to mix and match to find the right combination for your kid. So additional treatment considerations. Right? So we talked about the antecedent. options, the fading, the texture fading, the non-contingent access to something, the presentation methodology. We talked about consequence options like escape extinction, attention extinction, DRAs, reinforcement procedures, and response cost. So what other things do we need to be thinking about when we're thinking about putting together a treatment package? So you brought it up in the back, self-feeder versus non-self-feeder. That's a hard decision to make for some kids. We've talked about that a little bit already. Do we want to do differential social attention or non-contingent access to a preferred item? Right? Those are two really good options. What kind of sort of enriched environment do you want to have? Is social attention reinforcing for a child? And is that enough? That's always my preference. My preference is not to bring a toy into a meal because generally people don't have toys or iPads during meals. But when I will bring in, for the most part, a non-contingent access to a preferred item, putting on an iPad, giving them just non-contingent access to a toy that they really like, I usually do that in response to crying, right? If a child is really upset for the first 5 minutes of a session, I'm like such a softie. I really don't like when kids cry. It makes me very sad. So I will bring in something, pretty early on if a child is upset and crying. And I'll just sit and play with them for a little bit to get them used to what's going on and used to the environment before we even start with any food. Because if they can't sit in the chair with no food being presented calmly, right? That's step one, sitting in the chair calmly. So generally, I'll bring in a preferred item if a child at the beginning is crying, or say it's hard to separate from the parent at the beginning. I'll have them come into our, our toy room, and they can pick whatever they want, and then they're really excited, right? Part of that is really building a relationship with the child, and I think some of these reinforcer protocols can help do that. Escape baseline. So we didn't really talk about this to begin with, right? I talked about that I don't do an FA, mostly because all the research has shown it's escape maintained, maybe a little bit of tension maintained. But I do an escape baseline for the first 15 bites, right? I showed you on our data sheet, we chunk things up into 5-bite sessions, right? So for the first 3 sessions, I may do an escape baseline where I'm really mimicking what happens at home. Take your bite, problem behavior, okay, you don't have to. 30 seconds goes by, take your bite, problem behavior, okay, you don't have to. Because I want to see, does my intervention make a change, right? What's our baseline here? What's our baseline, and does my intervention actually affect that baseline? I also do it for the first, session, I may rotate between 3 escape baseline conditions. So one generally is an empty spoon. Will a child take an empty spoon from me? If they can escape the bite, take your bite. Okay, you don't have to. Ooh, sorry. See back there? That's a close one. And then the second condition I have is preferred food. Will they take preferred food from me? Take your bite, problem behavior. Okay, you don't have to. And then the third condition I'll run is the non-preferred food. Will they take the non-preferred food from me? And then I'll make my treatment decision. That'll help me figure out, where do I start? Some kids, I gotta start with an empty spoon, man. Because that's already hard enough for them because it's a new environment, there's a new therapist, it's a new space. So sometimes I'm just gonna start with an empty spoon and figure out from there what's my next step gonna be. So during my first session, I'll run a whole session of escape baseline, just rotating between 5 bites of empty spoon, 5 bites of preferred food, 5 bites of non-preferred food. And just keep doing that so I can have 2, 2, and 2, or 3, 3, and 3. And then I can make a decision. That's going to help me figure out, where am I going to start with this kid? What's going to be the first easy step? Because if a kid won't take an empty spoon from me, guess where I've got to start? No food in the room, empty spoon, and getting him to take an empty spoon from me. If he takes his preferred food from me, right? If he were to take his preferred food from me, then that's where I might do all those different colored squares. Okay, great, let's start preferred, 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 preferred. Preferred, preferred, banana, preferred, preferred. Preferred, preferred, right? Then I might go down that route. Now, I definitely see a lot of kids who will take their non-preferred from us. Right? That's when I go, okay, parents haven't been offering food in a long time, or this is a parenting problem, not a behavior problem. And there's going to be a big focus on parent training. right? So that escape baseline will help me figure out, where do I start with this child, right? Again, when I bring them into their room, are they hysterically screaming their head off before I even give them any food? Let's bring in a preferred item, right? My goal during the first session in the escape baseline is to really figure out, where can I start with this kid? What is the easiest task that I can expect for this child? And then persist with that, because that's where that escape extinction, the non-removal of the spoon, or the 4-step guided compliance comes into play. I know that once I put a task out there, I am going to persist. But what is the most reasonable task for this child? Is it an empty spoon? Is it a rice size of preferred food? Is it of non-preferred food? Is it preferred food? So you have to get a baseline to really figure out, what components are you going to start with. Right, so there we go. Escape baseline, what does that look like? You're going to present a bite every 30 seconds. If you remove the bite contingent on any level of refusal behaviors, if there's CI, crying, negative statements, okay, you don't have to, bud. And you give them a 30-second break. All right, we talked about where to start. You have to think about what bolus size you're going to use. You have to think about what texture of food you're going to use. Again, if you're thinking that a child has generally been having softer foods, maybe it's pureed foods, or if you know that this kid's going to really have problem getting the food in their mouth, maybe you start with pureed food. The ratio of preferred to non-preferred foods, that's where we had that color chart. How much preferred foods do you want in the session versus non-preferred foods? Do you want to alternate bite by bite by bite by bite by bite? Do you want to start with one non-preferred food and work your way up with just that one? Or do you want to start with a number of them? Level of choice. I don't think we give our children enough choice in terms of what's going on. I think we need to be better about, at least the feeding community, needs to be better about programming in more choice for kids, right? So when especially a higher functioning kid comes in, I'll say to them, hey bud, here are a few different spoons. You can have this teeny tiny one, this one that's about this big, or a full spoonful. Which one do you want, right? When given that choice, I can't tell you how many of the kids will be like, okay, I'll take the small one. And then there's no problem behavior. Great. If you take the small one, that works for me. Fantastic. There's so many kids who will then very easily take something if you give them a choice. Or when we're getting new foods on board, right? Usually I get those 4 foods on board, and then I programmatically bring in new foods. That's when I'll tell the parent, okay, we want a new vegetable. What vegetable do you want them to eat? Broccoli. I really want them to eat broccoli. Okay, bring in broccoli and something else. Okay, carrots. So then the next session I'll say, hey bud, do you want to try broccoli or do you want to try carrots? I'll do broccoli. I do not want carrots. Okay, great, let's do broccoli, right? Giving children a choice is going to be really important because within that context of choice and within that context of giving them some options, so many times we can avoid problem behavior because they would rather do this one, just don't make me do that one. Okay, right? I have a parent who really wants to get eggs on board. Really, really, really wants to get eggs on board. And I've said to her so many times, bring in eggs and some other protein that you think he's going to find super disgusting. Fish. He chose fish and he eats fish beautifully. All right? I really want eggs on board. Okay, great. Bring in eggs and then bring in another protein that you think he's not going to choose. I don't remember what it was. Peanut butter. Guess what? He chose peanut butter, right? Within this process of trying to get him to eat eggs, he very easily got on 4 different proteins. So at that point I said to mom, with the 5th protein I already got on board already, with those original 4, he now has 5 proteins. Do you really care if he eats eggs? Really? Do you really care? That's where I also have a conversation with the parents. I usually talk about if the child has about 4 foods in each of the food group, in a food group, that's pretty good, right? Bananas, apples, oranges, and grapes. Okay. Chicken, beef, eggs, and beans. Or let's not do beans. Let's do something easier. Hot dogs. Okay. That seems pretty reasonable, right? Is your child going to eat everything under the sun? No, but no one is. All right, so I usually talk to parents that 4 foods from any given food group is a decent variety, right? So it's also managing the parents' expectations. And then what is a reasonable expectation for that child who has 4 foods from each of the food groups? That they'll try a small bite. And we work with parents and we work with the kids to be able to have them just try the bite. There's so many times, and I have one child in particular who's on the spectrum, that every time she brings in a new food, you give him a choice, he makes a choice, he takes a bite, he goes, oh, it's really good. Right? Because so many times kids just don't like the food because they've never tried it, and there's just this gut reaction of, oh, I don't like that. But once they actually try it, they're like, oh, it's pretty good, because food is pretty good, right? So that's a really important thing that I don't think the feeding community does enough of, is giving choice, either of bolus size or where to start, or level of choice of what kinds of foods do they want to begin to integrate. Now, this is not an open-ended choice, and I acknowledge that. It is a multiple choice that parents sort of get to put the parameters on, but it's building in choice for some of their preferences. At the end of the day, is it okay for a child to not like a food? Yes, right? We have a child right now, Christina and I, where they just don't want to eat beans. We've gotten all these foods on board, and he continually gags, and he continually has problem behavior on beans. Parents are Latin. It's killing mom that he's not eating beans. But at the end of the day, I said, look, if we can get these other proteins on, I think it's fair for him to have a preference that he doesn't like beans. Okay? When is it appropriate for a child to have a preference and when is it not? It's a very slippery slope, right? But for our children who are super, 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 so restricted and so picky, I'm sorry, bud, you don't get a choice anymore. When we gave you a choice, you chose nothing. But as you get more foods on board and as that behavior subsides, so you can actually introduce new foods, I think it's appropriate to be able to integrate choice into the child's repertoire of, do you want to work on fish or eggs? And if that child never eats eggs, I'm okay with it because he has 5 other proteins that he can eat. So I think that's a really important piece that a lot of people don't think about. Right, so that's that learning curve. That's that learning curve of, we could teach children absolutely to like new foods, okay? And there is some research on there that maybe it takes up to 10 times for a child to actually begin to tolerate a food. I don't even talk about liking a food, right? At first, it's just to have a child tolerate the food, and hopefully over time, tolerating a food leads to enjoyment, okay? So the question is, should there be multiple exposures? Again, at what level is the child? I don't like eggplant. I eat every other vegetable under the sun, literally. I will eat any vegetable. I don't like eggplant. Is it okay that I don't like eggplant? If it's eggplant parmesan because it's fried and breaded and cheesed and all that, fine, I'll eat eggplant parmesan. But my husband loves like roasted eggplant, and it just gets slimy. It's just so gross to me. I don't like eggplant. Is it okay that I don't like eggplant? Could I get myself to like eggplant? Sure, if I was motivated enough. Same thing, could I get everyone in this room to like crickets? Sure, but are we motivated enough? Nah, I'll pass, right? So, again, do they need to continue to try? It depends what you're talking about. When you're talking about a 2-year-old, 3-year-old, yes, present, make them take a bite. But at some point when you're 10, 15, is it okay if they have enough other foods in their repertoire that they just don't like eggs? I'm okay with that. I think that's okay. What is a reasonable request to be able to have on these children of what our expectation is for them in terms of their feeding? Does that make sense? All right. Caregiver training. Oh, yes, go ahead. Norms for what? Like, you're saying, what is the descriptive information? Like, how many foods are they eating? I'm sure that's...
Maybe that's not generalizable enough, but is that something people are looking at?
I would think that there is a pretty good food categorization of what kids are eating. I don't know those data offhand, but I would think that there is. I would think so. I also know that the nutritionist that I worked with closely in Atlanta, she would say if you have 3 to 4 foods within each food group, you're nutritionally going to be okay, right? But does that help parents who are like, yeah, but they won't eat my beans? Okay, then that's maybe working with the parents a little bit more about reasonable expectations. So caregiver training. I always say it doesn't matter how well a child eats in the clinic. It really matters how well they are going to eat at home with the parents. So there always has to be an eye as to what's going to go home and what's going to go home well. What is the capacity for the parents? Some parents get trained in literally one session and they're home feeding and they are doing it. But the way I generally do it is once level of success is attained in the clinic, that's when I initiate caregiver training. Mostly because, again, if there's problem behaviors, I don't want it reinforced at home. And then what I do is basically a training procedure of caregivers implementing successive aspects of the protocol, right? So first they'll implement the consequences of the protocol. Great job taking that bite. Great job swallowing while I'm doing everything else. And they're maybe giving the iPad. If there's a DRA involved, they're in charge of the consequences. The next part is they're in charge of the prompts. Either if they're doing a self-feeding protocol, well, they'll say take your bites, or they'll be in charge of the mouth clean check. Show me like this. You do it, show me. So then they'll do the consequence and the prompts, and then they'll do the bite presentation where they're actually giving the bite and saying take a bite. And I break that up also. So first I'll scoop the bite and I'll be in charge of the timer, and then they do the rest of it. And then once that's successful, then they can scoop. Once that's successful, then they take the timer. And then once that's successful, and I take fidelity data across all parts of it, I'll then have them take data. And I have a caregiver data sheet, which is a lot easier to read than sort of this more clinically one that I gave you. And the reason I have parents take data is because I want to know how it looks at home, right? We know that caregiver report can be helpful and oftentimes inaccurate, right? Especially if you're talking about 7 meals, right? I'll have a parent come back and be like, oh my God, it was horrible. And I look at the data, I say, you're right, the first 5 bites looked tough, but the next 30 looked really good. They're like, oh yeah, the rest of it went fine, right? So caregiver data is really important because if I'm gonna fix anything at home, I need to know what's going on at home. So caregivers are really good feeders by the time they leave our program. And then we send home reasonable homework, right? So maybe the first time they go home, they only feed 10 bites a night. Or I may give them a fading procedure. If it's good for 10 bites a night, here's your success criteria. After 3 days, go to 20. After 20 bites, well, then they usually have been back in the clinic because I see them once a week, right? I may give them sort of some different options. And then I teach caregivers how to introduce new food. So they'll watch me do it, giving them the choice. Hey, bud, what food do you want to do? What food do you want? What bolus do you want? Sometimes we'll start with a small bolus and then work our way up with that one food, right? And then we'll go from there. So that's a really important piece to be able to train caregivers. And then over time, caregivers naturally will get rid of some protocol aspects. They'll stop the mouth clean check. They'll stop the timer. Right, which is fine. And if the child responds appropriately, great. What happens, right? When does it fall apart? Parent comes in, shows me their data, it looks horrible. I said, what did you take out? Well, I mean, what didn't they take out, right? So over time, I will gradually help them get rid of that scaffold, but we do it in a very systematic way to ensure that the child is still being supported. Yeah, you had a question?
Yeah, we don't have, or I don't have.
Oh, these last few slides, I'm sorry, I added them late.
I was wondering if we could get.
Yeah, sure, I could imagine. If you have, do we have emails, Mary Ellen? Yeah, I could. Great, perfect. Yeah, as I was thinking about it, I was like, I forgot a few slides. So I put these up. And then also the other piece that that I didn't make a slide for, I didn't think about putting in, was what is success? How do you know when to move on to the next step? How do you know when to move from right size to 1P, from 1P to 2P to, what I generally talk about is 3 out of 4 sessions of success, right? And I'll write this up on the board. Except not with that pen. So when I talk about success or moving up a step, I usually talk about 3 out of 4 sessions of success. That means 15 out of 20 bites. So we saw in the data sheet they're chunked by 5-bite sessions. So 15 out of 20 bites need to have at least 80% acceptance. So that's either 5-second acceptance or IVG acceptance. IVG acceptance. And at least 80% mouth cleans. I don't expect 100% because I don't ever function at 100%. So I don't expect our kids to either. So if you have at least 80% good acceptance, at least 80% mouth clean, so 80% or 100, and then no more than 20% CIs or expels or PACs or neg voces, then that's a successful session. That means 1 out of 5 had some sort of CI or had some sort of problem behavior. And 4 out of 5 had all the behaviors you wanted to see. So 3 out of 4 sessions at that with the right size bolus, I'll move up to a 2P bolus or a 1P bolus. After 3 out of 4 sessions of that, 2P bolus. 3 out of 4 sessions of that, half level. 3 out of 4 sessions of that, level, and then deciding what the next task is to address. So when I think of what is appropriate progress in treatment, generally, I can say pretty definitively, I'm moving up 1 step, at least 1 step every session. I'm getting at least 3 out of 4 sessions of success where I am, at least once per session. Sometimes I can go up 2 steps depending on how successful we are. But if we're not moving on a regular basis up 1 step every session, something's wrong. You need to figure out something else that's going on. What are the behaviors that are holding you back? Are they CIs? Is it crying? Is it expels? What's holding you back from moving forward? And then you have to figure out a new intervention based on sort of the plethora and the menu I gave you that's going to address those behaviors. So that's how we know when to move up. Now, if you've plateaued, right? If you have a session where something's not going right, again, go back and see what behaviors are holding you back. Do you need to add in a DRA? Do you need to, start at a different session? Start with a lower bolus size. Do you need to add in non-conditioned access? I don't know what it is because I don't know what the behaviors are. But you got to look at those behaviors. That's why your data, again, is so important, because that's going to tell you what's holding you up, and then you can go back and look at all the different intervention options and see what you need to add in. Right? I also just had a student who, it was a younger boy, and he was crying quite a bit. And he finally stopped crying after 2 sessions. And then he was so crying got under control, check. Next behavior was acceptance. So it was taking him a while for him to accept the bite. So the session after, I said to the student, I said, how'd the session go? She goes, it was horrible. It was a horrible, horrible session. I said, what happened? She said, he kept spitting out the food. I said, well, was he calm? Yeah, he was calm. Were there any CIs? No, there were no CIs. Did he accept the bite? Yeah, he accepted the bite. All he was doing was spitting out the food? That's great for this kid, right? So if you think about that hierarchy, the first thing you gotta do is be calm. Then great, let's target acceptance and CIs. And then if he's spitting out the food, okay, I have something for that. But don't worry about the whole package, right? You gotta break up those steps and address each of those steps of the feeding one at a time. Calmly sitting, accepting the bite, and then maintaining the bolus. I said, we'll put representation in next week, don't worry. But this was a successful session because he was calm, he took the bite, and there were no CIs, right? So you got to really think about what is success look like for each session. That doesn't look like success for my kid. If he's sitting out like that, there's a problem, right? But for this child, that was awesome. That was really awesome. So it's really also being able to identify what is success going to look like for each child at each different stage of treatment. It could be, does it look bad that he's spitting out all that food? Yes, it does. I acknowledge that. But that's success for this kid, and then we'll move him on to the next step, and we'll address the next behavior that pops up. But thinking about incrementally what does success look like is really important. All right, just to finish up, graphing and progress monitoring. I always think it's important to think of what is a feeding graph, what do feeding graphs look like if we're going to really graph the behavior. Excuse me. So we have our percent acceptance up here on the y-axis and our session number down here on the x-axis. We have our different phases of treatment, our escape baseline, right? You start off with take your bite, okay, you don't have to. Take your bite, okay, you don't have to sort of see what level are we functioning at to begin with. Then we have escape extinction and non-contingent reinforcement. This is non-contingent access to a preferred item. So the bite stays at his lips and he gets access to his toy. Then we move into representation right here. So I could imagine we'll talk about why that happened. And then this last phase here is escape extinction plus a DRA for clean mouth plus representation. So we'll see those different aspects of the protocols that sort of get added incrementally. So if we're just looking at acceptance, right, escape baseline looks bad. It's down here. We put escape extinction in play. You hold it up to his lips. Guess what? It's dad here, but guess what? It goes up. And acceptance, for the most part, stays nice and high. So if it stays nice and high, why are we changing anything in the protocol? Because he's accepting all those bites. Let's see. Let's look at his problem behavior. Again, our escape baseline, it starts out super high. Escape extinction goes into play, plummets pretty low, and stays pretty low the whole time. Okay, there's a pop-up here or there, but not bad. All right? Again, if it's looking good, why are we changing components of our protocol? Because if you look at something like expels, we see a different story. So escape baseline, first of all, there's no expels because he didn't accept any bites. So of course he's not going to spit anything out. Escape extinction, we see 0 expels per bite. Then we see an increase here, so they put in representation, and then it goes back down. And then we see it leveling off with no more expels per bite. And then we have our percent of mouth cleans. So mouth cleans are low, 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 meaning he's accepting those bites. He was then spitting them all out. We put representation in play. He's still not swallowing them. So what did they do, right? He's still not swallowing them, even though he's accepting them and keeping them in, right? So that means he's accepting the bites. He's not spitting it out anymore. He's just packing it inside his mouth. So now packing is the concern. So we started with problem behavior. We then went to acceptance. We then targeted expels. Now we're targeting packing. So they put a DRA in for clean mouth. So every time he swallowed, he got access to his preferred item. And then what happens? We see a nice increase right here. He's super motivated to get access to that toy. And then we go up to a higher bolus. We go up to even higher bolus, and then we start parent training, and these behaviors stay nice and consistent. So it's really important to think about the different graphs that are going to tell you different information. And this is a great example of really incrementally looking at the different ways the different ways of addressing the behavior. Because if you're just looking at acceptance and you're not graphing it, this looks beautiful. I don't see the problem. It's really, again, looking beautiful. I don't see a problem. It's these expels that we're talking about. So you have to then identify that and target that. And then you have to be able to identify and target the packing. So that's how graphing can really help you figure out what really are the behaviors, what trend are we looking at in our behaviors, and what trend do we need to then address with our interventions. That's what I got for you guys. Who has any questions? Anyone? Anyone? All right. Few minutes before 4. Is that, yes?
How many sessions do you typically see a child per week? Do you do one?
For our general outpatient, I do one 45-minute session per week. For our intensive outpatient, the children who really have intense feeding, that's the tube weaning, that's the formula-dependent children, we'll see them 5 times. We see them every single day, Monday through Friday, for 3 meals a day. So, and then we'll see them for 6 to 8 weeks. So those are some intense behavior kids who really need some intense services.
And then when you start parent training at different times?
I generally start parent training after we have gotten those 4 foods on board at a good amount of bolus, at a large bolus. Again, because I want it to look successful and I want there to be very low problem behavior before sending something home with them. Now, it could be that if I started with puree and they eat higher texture food, I may get the texture up first, right? I want to do the heavy lifting, and I want to send them home with the easiest thing because it might be really annoying for parents to, if I think that texture is going to be a pretty quick thing, it's really annoying to have parents puree food all the time to feed them once a day. So if I can knock texture out in a session or 2, I may do the texture first and then parent train. But I will generally parent train, say I'm doing a non-self feeder protocol, I will generally parent train a non-self feeder protocol, and then I'll work on self-feeding in the clinic while they're still getting the continued practice at home. Or I then may teach parents how to introduce a new food and then do the self-feeding. So generally I'll ask parents, what's more important for you right now, that he's eating more food, a wider variety of food, or that he's feeding himself? And I'll talk with the parents about sort of what's their hierarchy of interest. All right.
Let's thank Roseanne. Feeding is a problematic area for so many families, and so it's really so. Would anyone like some flyers? Want to raise your hand and I can count who it is? Anyone else? Thank you, Roseanne. We'll also, we're sending an archive, Roseanne gave us permission also to do an archived version, so we'll be sending that out to you if anyone wants a copy of that. Thank you, have a wonderful day.
So now, and next week you said, this is super behavior. You look at that. Let's do it.
See you. Have a good Thanksgiving. Bye, Kelly. Take care. You too. Bye.
Oh, great, thanks a lot.
Yeah, do I? Oh, got it. Okay, thank you.
All right, do I have dogs? We do not. I do have them. Probably go there.
Yeah, so here's what happened last time. They sent me a certificate and then I used the certificate to put it on CD
Okay, that's what I want to make sure.
And it was easy to do. It was the first time I had done it.
Yeah, it's easy. I just wanted to see, should I, when I get it, should I think about doing it myself? Or do you have-
Yeah.
Okay.
Yeah.
Thank you.
You can park your gas. Yeah.
So, yes, when she gets it to us.
Okay.
So the handout she sent was the one I sent to you.
Yeah.
So she'll resend that, absolutely. Yeah, you'll probably get it automatically, right?
I mean, we were out there lifting because they're not punched.
But hey, if you didn't scrap anything off, bring it back with you next time.
Okay, no problem.
And put it in your window.